Okay, we are now recording. It is our spring 2021. We will be coming into the summer. It is May 10th of 2021, and we are offering a National Registry prep class. We will try to encompass for EMT basic in the first part of the day, and then we will try to focus more so on advanced EMT curriculum or information in the second part of the day. Along the way, when we cover something such as anaphylaxis, 90% of the information is universal from EMR all the way to paramedic. It's your scope of practice that you're allowed to do to fix the issue is what is different. So everything involving recognizing a condition is universal for the most part. So we will teach the same information, and then we will take time to distinguish the scope of practice differences for each level of licensure. All right. This being said, I'm fixing to share one of the first things that we will share on our screen will be a PowerPoint type presentation. And this is something that I have some talking points on here. All righty, so things to know about the exam. And we're going to kind of move fast, but those who are on our virtual team here should be able to see our slide. And the emphasis here is less than, statistically, according to the registry themselves, less than 1% of the people who take the registry test run out of time. You got to remember that and tell yourself, take the time you need. You must be able to synthesize the question. The question is going to be the stem. They call it the stem. And then you have 3 distractors and 1 key. The key is the correct answer. So you need to identify what it is the stem wants you to give it. And then you need to be able to take the time and read clearly. Watch out for words such as accept. Watch out for words such as should you do next? Because if it says should you do next, that means the very next thing that needs to happen. Yes, you know that you need to do blah, 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 blah. But if it says what should you do next, then think about the appropriate chronological steps. These are examples. You need to take the time to read carefully or else you may cheat yourself out of a correct question. And then the next thing that I always take time to emphasize on is that you need to erase fear if at all possible. The reason that fear is a problem with this, because if you're afraid, if you have fear of failure, if you're afraid you're going to fail, then fear is a dangerous thing because it is like love. It's a very dangerous 4-letter emotion. Either one of these emotions can make the human mind lose 50% or half of its cognitive ability. So if you are taking the exam and you're afraid you're going to run out of time, you're afraid if you don't pass it, you won't be able to keep your job. If you're afraid you don't pass it, you're going to have to spend more money that you ain't got. If you're afraid that if you don't pass it, then you're going to look like a fool while everybody else in your class is going to look like the smart ones. And they're going to get all the jobs and you're going to be left hanging. Well, I'm here to tell you there's plenty of jobs to be had. So don't let something that foolish make you have fear. My point is whatever it is you're afraid of, then you need to hit that head on and get that behind you. Don't, if you're afraid of failing this test, then honey, maybe you ain't ready to take the test. Don't waste your time and your money unless you feel confident. People take the registry exam and then they show up and they're like, man, I can't believe I passed. And I tell them, I can't believe you wasted your time and money then. Be surprised if you fail. Don't be surprised if you succeed. Does this make sense? If you are not fully anticipating passing the exam and you don't feel confident and competent in your knowledge base, then perhaps you got some more work to do. That's the point to make there. You can't, now, the other point behind this, if you are on question 24, and it is a very difficult question, and you do not know that answer, and you had to guess, and now you worried about that question on question 25, 26, 27, 28, 29, 30, all the way up through 47, you still worrying about what happened on question number 24, if you let it get in your mind, then that means that every question between 24 and 47, you have answered with only half of your cognitive ability. Why? Because you were still afraid of your mess up on 24. You got to let go of it. It's like a bad relationship. You got to leave it behind you if you're trying to move forward. All right, you need to break up with that question and let go of it and move on to the better ones. See what I'm saying? All right, fair enough. Now, so there's essentially, what I want you to think about is there's kind of two approaches. Questions, so there's the questions that will be about how to manage a patient. How to manage a patient. The way in which you need to prioritize your answers to those questions, obviously anything BSI scene safety, right? But primary assessment, anything that indicates instability of the patient is where the answer is going to be. It's going, if it gives you anything that indicates instability of the patient, then you need to find an answer that is an aggressive action in your scope of practice that is would fall within the primary assessment, an airway, breathing, or circulation problem. Otherwise, it might be something very skill, knowledge specific about what would you do with a traction splint. You know, we only put traction splints primarily on fairly stable people to begin with. All right, not that I'm not saying you wouldn't put one on, but it wouldn't be one of the first things you do with a critical patient necessarily. And then the next thing is you need to think about the order of priority in which you would answer a question that is about a scene. A question that is about multiple patients or the scene itself or the situation. Questions about more than one patient, the scene overall, or a question regarding a situation is most likely an operations question. Operations seems like it should be the easiest. And because we think it is the easiest section in the exam, because of this, people spend the least amount of time studying that information. Once we take a brief overview of some of this information that I have to introduce, then we will probably today, I want to try something different. Today, we're going to skip straight to operations. It's little things that matter the most. For example, when you hear the word triage, audience here in the classroom, what do you think when I say triage? What goes through your mind when I tell you? Yes. People think about triage and MCI, but there's also a second type of triage. There is the triage of the trauma patient, the one single trauma patient. And that type of triage is called, you're triaging their injuries to determine what kind of destination they need to go to, what level of a trauma center. And that's based off of the 2011 CDC trauma destination field guideline. It's 4 primary categories. We'll discuss that when we come to it. If you don't know what's in that document, what's in that information, then you will possibly get confused when why is it asking me something about triage with only one patient? It's because it's a separate type of triage. So, but generally speaking, triage does apply to sorting of multiple patients, which is a very easy process, but there are key things to know about. It's pretty obvious who's black tag and who's a green tag in triage, but the confusion is between the reds and the yellows. There's 3 simple things that I'll show you to differentiate those. And that's what you will want to have in your mind as far as how you would address those questions. All right, enough about that. All righty, so the way that you would prioritize, again, on a patient question, you're looking at your starting information. There's your primary assessment. So it's C, ABC, if it's a trauma patient, because C would determine how you open the airway. If there is considerable mechanism of injury indicating the likelihood of C-spine trauma, then you would want to open airway with the modified jaw thrust versus head tilt chin lift. See what I'm saying? So if it's just a medical patient, you can go straight to the A and the B and the C. Y'all know what that means. D is standing for deficits and disabilities. In a trauma patient, if you detect that they are unable to feel their legs or move their legs before you ever go to get them out of the car, that's something you need to know and be able to document. And you need to be able to find that quickly in that primary assessment. Otherwise, 6 months down the road, when they take you to court and say, you weren't able to document that, now it looks like something we may have caused. And then E is important. E stands for rapid extrication. E is extrication. And you would E, based upon their environment or any potential E exposure. If there was an immediate life threat, primary assessment deals with immediate life threats. If there was an immediate life threat that is due to their environment or an exposure, then that is some action that must be taken in the primary assessment as well. They're in a vehicle and the vehicle is on fire. We will bust the glass, cut the seat belt, and try to pull them through the window if we have to, if we can get the door open. Life over limb. Is that the normal, most best practice way of getting somebody out of a damaged vehicle? Absolutely not. But when they're fixing to die because of it, then it absolutely is. And so there are things that would justify rapid extrication, which is not the best practice, but it is better than them immediately dying due to the environment or exposure around them. See what I'm saying? All right. Now, the thing that I want to clarify right now, I want to clarify something right now. Primary assessment is ABC, airway, breathing, circulation. However, primary assessment of any unresponsive patient is, according to American Heart Association, that's the exception. Unresponsive becomes CAB. And an unresponsive patient who is presumably in cardiac arrest due to the need for emphasizing faster, sooner, more quickly delivered high quality CPR and early defibrillation, this is why there is an emphasis in CAB. Did I start? I did start the recording, didn't I? Yes. All right, perfect. So, and then going over to, so remember that. ABC is the primary assessment on everybody, except the unresponsive patient. Unresponsive patients, it's compression or circulation issue, then airway, and then breathing. All right. Also understand that in a critically injured trauma patient, such as a TCCC environment or TECC environment, tactical medicine, someone who is exsanguinating, that is massive arterial blood loss. The emphasis there would be on stopping the bleed, then addressing airway and breathing circulation, airway and breathing issues. Because here's the thing, if all of their red blood cells spill out onto the ground, then what good is it going to do to put any oxygen in them? They no longer have a method of carrying this oxygen. So unresponsive patients, critically injured trauma patients who are exsanguinating in front of you, who need tourniquets, there's a focus on C, which in a cardiac arrest patient, higher emphasis on earlier chest compressions, high quality CPR, early fibrillation, and a critically injured trauma patient, stopping the bleed ASAP before moving forward. All right. So scene questions, ops questions. The answer priority, what you would want to pick as the best answer If it is a question about a scene or a situation, if it's a situation, it may be like a medical legal type question. But like a scene type question, the same thing you say that you regurgitate when you walk in and do your skill stations. BSI, scene safety, number of patients, mechanism of injury or nature of illness, and additional resources. If the scenario covers the first four of those things, and the next, it says, what should you do next? And it tells you got like 6 patients. Well, then the next thing you should probably do is request additional resources. Another 2 more ambulances. See what I'm saying? All righty. So the scenario will give you so much of that, and then where it stops is probably where your answer's at. What needs to be done next? And that's the order of priority. And you already have that memorized, don't you? Because of everything you had to say when you walked in a skill station. BSI, scene safe, number of patients, mechanism of injury or nature of illness. What other additional resources do I need? So you go from there on that. All right, moving on. Moving on. Look, who comes up with the questions? A bunch of really smart people who gather, and they would have a compendium of all the industry standard texts on the table as a reference. And this is a mixture of field level folks, educators, administrators, legal experts, and doctors. And then it is agreed upon. There's a huge bank of these questions submitted, and the ones that are submitted are reviewed by that panel of experts. All right. So look, computer adaptive testing, what that simply means is this, is for basics, you are going to kind of ride the fence a little on the paramedic test. They kind of ride the fence a little, and then there's these different linear exams and the computer adaptive test, all these different highfalutin $35 ways that they've come up with doing this. For AEMTs, you typically have a set number of questions. Now, was a set number of questions, but now some of the ways that you can take it from home, it's a little different. But either way, here's what I want you to know most of all. There are pilot questions. All righty. Now, I've heard some people say, well, there are not pilot questions if you take it at home. There are pilot questions if you take it at the typical testing center. Here's what I want to tell you. If you see something that you ain't never heard about before, it could be a pilot question. So the paramedic exam, for example, has 20 of these. The exam that's for EMTBs and AEMTs, in some cases, had even more of that. What a pilot question is they're trying to see if it's going to fly. All righty. They want to see if enough people, good morning, sir, if enough people have heard about it, if enough instructors are teaching it now, those sorts of things. All right, those sorts of things. But here's my emphasis. This is the main thing you want to know about a pilot question. If it's something you ain't never heard of before and you have no idea, pick the best answer you can and then move on. Quit worrying about it. Because if that's it, if that's what that is, it don't count for you or against you. My concern is that a pilot question, if something you have not heard about before, it could cause you to stress out and to get hung up on that and then begin to be afraid that you missed a question. And then that gets in your mind from now on with all the questions that do count for you. So you hear what I'm telling you there. Don't stress over that. Don't stress over that. All right, cool. This is a link that we will actually look at this later. Is something I just simply need to share with you. I ain't gonna go over it with you because that it would be an entire day long class in itself. It's something that you need to look at and you will need to research and comprehend and read over. And I'm going to show you how to navigate it. But anyhow, now this is what we will be looking at today. This is excellent information. This is what's known as a National Core Competency Program, or NCCP model. It is what is from the National Registry, and they have the different levels. We will look over the EMT. I'll show you these, where to find this information, and go from there. Because based on what scope you're testing at, this document that I'm going to show you is actually, let's park on that just for a hot second. All right, we can go right to that. I'm going to go to a new share and I'm going to take you to it. All right, we have changed the screen. You should be now seeing the document from the National Registry. As a matter of fact, let's just take a reverse right here. All right, so you go to National Registry's homepage, NREMT.org. And you go down here to the bottom where it talks about recertification, National Core Competency Program. Recertification. You come right down here and it tells you the amount of hours an individual has to have for recertification. But look, training officer resources. As a training officer, this is what I'm sharing and teaching today. This is the education update. In other words, the bulk of what it is they want you to know. Well, guess what? That's also the bulk of what they're going to ask you on the exam. So it is probably the most useful tool out of any study guide out there. And I'm going to show you what I'm talking about. Raise your hand if you're AEMT in the room. You're testing for AEMT. Excellent. So there are one or two folks testing for basic. Don't worry, we're not going to lead you down any slippery slopes here. But because for the majority, I want to demonstrate and we were going to discuss, the majority of what is on here is the same. For folks at home, you should be able to see this. I'm going to go right here. You got 5 categories, friends, 5 categories. It leads you through. In other words, the content, go down to the lesson content. When it comes to skills, don't worry about that. We ain't doing skills, we're doing a cognitive exam. So it begins to go down through here. Adequate versus inadequate breathing. All right, you must understand the art of artificial ventilation. Artificial ventilation, number one, you got to move air. That's rate and volume. Number two, you got to move gas. That's getting O2 in and CO2 out. Real easy. And then you go, going down, for example, respiratory distress versus respiratory failure. One of my favorite subjects to teach because it sounds like something that just blows your mind. 22 years of doing this, over half of my career of doing this work, I had no idea what the difference of that meant. It was only when I began to synthesize it and to research it and discovered simple ways of understanding $35 words and complex medical knowledge. I had to do it in a simple way, in a way that I could apply it, being a kinesthetic or hands-on learner. Nowadays, I'm lazy, so I guess maybe I'm more of a book learner. But nonetheless, the simple thing that I want to share with you there, respiratory distress, you know what it looks like, right? Give me some examples of what a respiratory distress patient looks like. They may be in a tripod position. What else? They may be wheezy. It ain't easy being wheezy. They may be breathing harder and faster, trying to compensate by a higher rate because they can't get the volume they need. Why can't they get the volume they need? They can't expand their lungs like they used to due to emphysema, end-stage COPD, alveolar diseases, a multitude of conditions, may have fluid on the lungs. The point of the matter is, in the pediatric patient, it could be asthma. That can happen in adults too, but there's a lot of reasons. They could be suffering from bronchospasm. Regardless of what kind of breathing problem they're having, My first and foremost concern is how bad is this problem? Is it just distress or has it progressed to failure? And then how long before it becomes arrest? 3 levels: distress, failure, and arrest. Arrest is easy. If you've got a BLS card in your pocket, you know how to manage respiratory arrest. 1 breath every 5 seconds in the adult, 1 breath every 3 seconds in the pediatric patient. If the adult has a secure airway, 1 every 5 to 6. Those of us who understand capnography and are well versed in that, we know that we're going to kind of chase those numbers instead. But nonetheless, that all being said, here's what you need to know. How you know, who's somebody in here tell me, when your patient goes from distress to failure, what's the thing you'll see? Excellent. My man said altered mental status. Altered mental status. So you show up for a breathing problem, COPD, asthma, CHF, whatever. You show up. If they are no longer well-oriented, if they are somnolent, which means they can't stay awake, if they are obtunded, which means they're acting stuporous and drunk and those sorts of things, or you know, in a less than cognitive state, any of these things, lethargic, maybe uncooperative. I don't like the word combative because we don't like to use the terminology combative patient, because someone who is a combatant is trying to harm you and you can't get away from them. And they're beating you up. If somebody's beating you up, that's not a patient. That is an assailant. And you are legally justified to defend yourself from assailants. We don't strike or fight patients. So somebody who is beating you up is an assailant, not a patient. So the terminology of combative patient is something that we need to get away from as an industry for our own well-being in the court of law. Beside that point, back on target here though, is altered mental status is the thing you see, boom. So it's not complicated. But what this document does, it goes on down to airway adjuncts. Pay attention, please, especially those of you at home, right here on Roman numeral number 4, teaching point, airway adjunct. Let's go down to the objective B Bravo, nasopharyngeal, or NPA. Even though the 8th and 9th edition of PHTLS have come out and now teach us as an industry that nasal airways are no longer necessarily contraindicated in facial trauma. They are more of a precaution. And this was based upon witchcraft and voodoo and medical myth. It was never actually proven with evidence-based research that these would go into the cranial vault of a patient who had facial fractures. It was theory, but it has been taught forever. Now, even though we are in the process of changing this information, and for example, in our service, we'll put an MPA in somebody. All right, it is a precaution now. It's not a contraindication. However, based upon the current information that the registry is still going off of, it is a contraindication. All right. So I want you to stick with that right now for the preparation of taking this test. Regardless of what you may have heard an instructor say, regardless of what you may have heard in your last PHTLS update or class, regardless of whatever your service may do, according to the test that you're trying to prepare to take, it is a contraindication. So this is why this document is useful, because what's on here is what you're going to be getting tested on. Fair enough? All right. Talks about examples of supraglottic airways, Kings, iGels, whatever. It goes right down here to the disadvantages of them. All righty. Contraindicated in patients with a gag reflex. All righty. And on and on. Let's go down to Roman numeral number 6, neonatal resuscitation. Point number C, Charlie, presence of meconium does not necessarily require suctioning. Now, is that not a paramedic skill to use perform direct laryngoscopy with a laryngoscope and use an ET tube as a suction catheter attached to a meconium aspirator? Yes. However, recognizing the need for it is EMR through paramedic scope of practice. So everybody in this room, everybody who's joining us online needs to know that there is a time and a place to do suctioning. Used to, we were taught that you suction as soon as the head presents, that you use a bulb syringe and you suction the mouth, then the nose. In the alphabet, the letter M comes before the letter N. So mouth, then the nose. You no longer routine suction the nasal and oropharynx of the neonate unless there is a heavy presence of junk there. All righty. So do not suction a baby who exhibits vigorous crying and respirations. There's no need to. No need to. If they are a little bit slow to respond still, it's like the little on switch hadn't kicked on, or, you know, when the good Lord brings them into the world, you know, we want to crank them up to level 10. Honey, if they come out at level 10, they good. If they still about level 2, you need to turn them up a little, right? All right, if you see a bunch of junk in there, then suction that out. If you don't, then don't worry about it. It's when you're going to have a child that has been in utero for an extended period of time, greater, say 38, 40 weeks, then that is where you will likely have the presence of meconium or the in utero bowel movement content from the baby. But so suction if the newborn exhibits respiratory compromise and distress. Then you would suction them, and then you might need to bag them a little bit, very carefully. Very carefully. You bag them up a little bit. So the rest of this is just talking about the skills of this, and you're past that. You've already done that in class. So look, this is not that much information. But looky here. Anywhere in this content that you run across a hyperlink or a link that you can click on to go to something else, then guess what? That is taking you, oh Lord have mercy, what are we doing? As artifact. You know, when you hold a portable radio too close to a light bulb, a fluorescent light, old school. I don't know if it still does this nowadays, but you know, you can turn the fluorescent light on with it. That's what happened. I got my mouse under here, got a little too close. Artifact. But anyhow, moving on. Death by hyperventilation. This is an actual research paper that the registry themselves link you to tell you that if you overventilate, if you provide ventilations at too high of a rate, that is just as deadly as not bagging the patient fast enough or even going apnea. Over bagging the patient will actually cause their CO2 levels to drop. When the patient is hypoventilated, their CO2 levels rise, and that's very deadly. But when you bag them too fast, you drop their CO2 levels, which is actually just as deadly. It causes what's known as a shift of their oxyhemoglobin dissociation curve. Big $35 word, it simply means this right here. When the CO2 in the bloodstream gets too high, oxygen cannot attach to a hemoglobin protein in the blood. So it can't be carried to the cells. When your CO2 level is too low, oxygen, it can attach, but it can no longer detach once it gets to the cell. Either way, honey, you have an anoxemic injury of the brain tissue and everything else. The brain will be the first thing to go because it's more susceptible to the lack of oxygen. So this is the emphasis here. All right, moving on. Then it'll go right down in here and it goes to oxygenation. Oxygenation. This discusses a lot of important material, but here's what I'm going to park on. I'm going to park right here. All that fancy knowledge right there simply says this. You ready? There are 3 types of patients that you would not routinely throw oxygen at. The acute coronary syndrome, which means myocardial infarction, STEMI, chest pain, angina, pulmonary, any of those kinds of things. All right, so the chest pain patient, only give them oxygen if they are complaining of dyspnea, they experience signs and symptoms of shock, would most likely be cardiogenic shock. If they're experiencing heart failure, so they've got signs and symptoms of heart failure, CHF. Or if they have a pulse oximetry that's less than 94 on room air. Then and only then give them oxygen. But when you do give them oxygen, only give them 2 liters nasal cannula. All right. Tissue damage may increase when high concentrations of oxygen are given to acute coronary syndrome and stroke patients. The oxygen releases free radicals. Therefore, it is no longer recommended. These are byproducts of metabolism and that are toxic to neighboring cells. In other words, what is known as an ischemic penumbra. An ischemic penumbra, if you ever see that on a test or anywhere else, that simply is meaning it is an area surrounding the infarct. In an earthquake, you have what is called in the center, it's known as a what? The epicenter, right? So the epicenter of an earthquake is kind of like the area of infarction in the heart or in the brain due to a clot. Typically from a thrombus, which is a clot that forms in the heart, and typically due to an embolus, which is a clot that travels in the brain. That all being said, it's that area around there where the damage of the ischemia, lack of oxygen being delivered to the tissue, is growing, is what's known as the ischemic penumbra. And our goal is to corral that and keep that area of damage from this earthquake as locally as possible. Try to stop it from spreading. All right. That all being said, so strokes and chest pain patients only get oxygen if they have a pulse ox less than 94% on room air, if they have shortness of breath, or if they're having signs of symptoms of shock and or heart failure. So they're hypotensive or they have congested breath sounds in the chest pain patient, somebody who are there short of breath. All righty. This is more so with stroke than it is MI, but this is the new teachings. This was in the 2015, and it is also in the 2020 AHA guidelines. The registry test has now been updated to the 2020 American Heart Association guidelines for emergency cardiovascular care, ECC, emergency cardiovascular care. Everything in the resuscitation section is straight off the AHA 2020 updates, which is that link before this one, yes, bless you, that I can show you. The point of the matter is, so I told you there were 3 people who you did not want to just willy-nilly go out here and start throwing oxygen at. Chest pain patients and stroke patients, ischemic stroke patients. If you think you're dealing with a hemorrhagic stroke patient, then that's fine. But ischemic stroke patients and heart attack patients. And I've told you the exceptions of when you would do it versus withholding it. And then if you do give them O2, still we're not exceeding 2 liters nasal cannula. Now, if the patient becomes ultimately critical into arrest, then obviously you can go with your high flow on your bag valve mat. But generally treating these patients, that's what you need to look at. Let's scroll right down. The third patient that you would want to withhold oxygen from is not discussed exactly right here, but what you want to understand that in every section, primarily of the test, there's about 15% of the questions from the 5 sections are pediatric questions. 15% of each section are going to try to base that on pediatric information. So here we're talking about airway, respiration, and ventilation. Well, on just airway and ventilation there is a ton of information there alone for pediatrics. But on the oxygenation, here's what you need to know on pediatrics. It's the 3rd. And what this is dealing with is a neonate patient, postpartum neonate, so a premature neonate. In the premature baby that has been delivered in the field, or actually in the hospital too, but in premature neonates, fresh out of the mama, if they are premature, if they are less than, we'll have to check this here in just a moment. I believe it's 36 weeks. It could be 38. We'll have to check me on that. But the point is, when they're preemie like that, 36, 38, we'll have to check that in a moment, make sure I'm giving you the correct numbers. If you have to bag a neonate, it would be because the heart rate, the pulse is less than 100 on any baby, right? Any neonate. 37 weeks. I was in the middle. Oh man, everybody at home, did you hear that? The information on that is 37 weeks premature. If they're less than 37 weeks gestation and they've been delivered and they are not vigorous and they have a heart rate less than 100, you would bag them. You would do that on any baby fresh out of mama. If its heart rate's less than 100, you got to bag it. If the heart rate's less than 60, you need to start full-on CPR. If you're doing full-on CPR, give them high flow O2 regardless of gestation. If you're only having to bag the child, not yet having to do compressions, but all you're doing is bagging them, if they are less than 37 weeks gestation, and you know that, you may not know that, but if you do know that, you would try to first bag them at room air, 21%, 17, 21%, whatever you want to call it, room air. Then and only then, if that does not help speed the heart rate and increase the vigorousness of the child, of the baby, it says that you can go up to 65% FiO2. What FiO2 means is fraction of inspired oxygen. How much are you putting into the, so you turn your BVM up, there you would crank it up to about 6 liters. The point is you ain't going all the way up to 15. Generally speaking, about 1 liter a minute gives you about 10% FiO2. And you're already coming off of 21%. So room air is 20. All right, enough about that. So those 3 patients are who you would withhold oxygen in. And there are parameters around that that you'll need to be familiar with. All right, moving on. But this information that I will show you where to find is what you need to be focusing on. Okay. Then you go into cardiovascular post-resuscitation care. All righty. Post-resuscitation care. So cardiovascular is its own section. It's the second section, right? This is where you got to know your emergency cardiovascular care, your 2020 AHA updates. All right. This is where you want to know your updates and go from there. But the long and the short, I'm going to cover this one and we'll take a little break. When we take a break, we'll pause the recording and then we'll let everybody who's on virtually know when to jump back on their device and pick back up with us. But the biggest, so this is specific to post-resuscitation care, all right, post-resuscitation care. And in this, some of the content. You need to know how to recognize ROSC. It talks about there may be a pulse, they may start breathing, they may start moving. Number 2, Roman numeral number 2 is the answer that is straight out of the American Heart Association's ACLS and BLS tests. In a ROSC patient, the goal is optimizing ventilation and oxygenation in the post-cardiac arrest patient. So the biggest thing to do with that is you do not want to see 100% O2 sat. Your O2 sat goal in a ROSC patient is 94 to 99%. If you see 100%, then that's an indication that you may be overbagging them at too high of a rate. Point B, bravo, avoid excessive ventilation, overbagging. That reduces cardiac output and it decreases cerebral blood flow. All righty, it decreases cerebral blood flow. It changes the shape of the blood vessels in the brain, causing a decreased amount of flow of blood through those blood vessels when we drop their CO2 levels. All right, so we need to be very careful with that. All right. This tells us what we would do if the ROSC patient has hypotension. So anytime you see, we see activity on a monitor, we check a pulse. OMG, we got a pulse. You can kill them just by bagging them wrong. So we got this far. Let's not take them out just because we're not bagging them right. So that's the first priority. Then the next thing is, okay, so I got a pulse. How good is the pulse? Let's check a blood pressure. If the blood pressure is hypotensive, then I would do what? Need a fluid bolus. How much? All righty, so it says 1 to 2 liters of fluid is the AHA information on that. Now, 1 to 2 liters of fluid, saline is fine, normal saline is fine. However, LR would most likely be better. It is not as acidic as normal saline. And why would I be worried about acidosis? Why would I not want to give them a fluid that could make them even more acidic? They were just in cardiac arrest. That is one of the worst forms of respiratory acidosis and metabolic acidosis possible. Metabolic acidosis is the epitome of shock. And cardiac arrest is the worst possible form of cardiogenic shock. So cardiogenic shock at its worst is cardiac arrest. And that is like the worst possible metabolic acidosis you can have. Plus they were not breathing. So they also have respiratory acidosis too. So this is why I want to give, if they need fluid, they need fluid. I got to get pressure going to make sure there's blood getting to the brain in this ROSC patient. But I can do so with a fluid that has a little higher pH than the 5.5 or 6.0 pH that you get with normal saline. And I'm dealing with a human being that's got a pH of 7.35 to 7.45. All right. This thing right here, Roman numeral number 4, it talks about the targeted temperature management in post-arrest patients. Don't even be worried about that. If it were to throw a question at you, you just know that that ain't even really done in EMS. It can be, but logistically it's very difficult. It's very difficult logistically. Here's what you would know though. So it may say you reach the hospital and that puts you in the in-hospital scenario. So there you may need to know it. But and the long of the short is cooling using therapeutic hypothermia in a ROSC patient would only be done if the patient remains neurologically flaccid. In other words, they don't have any signs of movement. There are no eye movements. They are not starting to try to rebreathe over the tube or the airway that they may have in, those sorts of things. If they totally remain unresponsive, then and only then would we maybe consider making them cold, therapeutic hypothermia. And that has to happen with a couple of liters usually of chilled fluid. There are other ways they can do that in hospital, but some of the things that it says EMS could do would consider application of cold packs to the axilla, groin, and neck. Realistically, I don't know how good that's actually going to work on that, but is it something we do in our protocols? No, because we're realists and we go off of practical application. However, it is in the information here, so that's why I want to share it with you. All right, but that's the only time that would be done, is when the patient remains unresponsive and has gained ROSC. All right. And then point number point number 5, Roman numeral number 5 right here, the system of care to ensure coronary reperfusion. So it says may include making sure that we're going to a facility that is capable of managing a STEMI patient. So if the reason the adult cardiac arrest patient went into arrest is because of a big MI, then that's the only thing that's going to fix that is PCI therapy. What is PCI therapy? So the PCI therapy that is percutaneous, which means to go through the skin and into coronary intervention. So they come in from the outside and do the cardiac catheterization and will remove the clot. They may place a stent to help hold that area of thrombus open. All righty. So this angioplasty, balloon, whatever. All right. That's these types of things. But coronary reperfusion. All right. Enough about that. So making sure that we go somewhere that the patient can, because otherwise they're going to code again. They're going to code again. I've got them back and like we're coming through the doors, like they are, I mean, telling you 5-10 minutes from getting PCI. We're helping them prep the patient, having to get them prepared and everything. And I mean, like cath lab team standing there, the lights are on, the table's ready, the doctor, the interventionalist is there. He's taking our report and then they don't code again before you can get them in there. And so you work them real hard again and get them back. I've had it to where they've went in, you can't get them back. And they were like fixing to get needle. And it's that time sensitive sometimes. All right. So good. And then we're going to pause there. In the cardiovascular section, there is information that you would need to know about. They're no longer called LVADs because now they're just called VADs. When ventricular assist devices first came out, they were like left ventricular, so for the left ventricle. Now they are actually could be for either side for different types of problems. But what we will do is we are going to take, I'm seeing that it's 9:05 and we're going to take about 15 minutes because of break before we look at some other important information. And then I'll be giving you some other additional important links. We'll be looking at the tests there. And so for those who have joined us virtually, we're going to stop our recording here. So, and then what we will also do is, so we're going to, and we have resumed our recording. One of the questions that was just asked in the, chat box was saying, would this recording be available, or would this be available to be emailed back out later? We've recorded it hopefully on our cloud. It makes it easier to upload. Is everybody okay? So, but hopefully we'll be able to do that later. That's the plan anyhow. That's the plan. So that's what we're going to try to do. All righty. And I am trying to catch a quick call at some point from, it could pop up anytime from my doctor's office. It's what happens when you are fat and keep getting older and EMS. You have to have a doctor's visit. So if that happens, we will take just a quick remission. It won't take but just a hot second to do that for them to tell me if they can take care of that today for me or not. Otherwise, I'm gonna have to pull favors from all the docs that I know out there. So let's change gears. The point is, so the point is, you see that this document right here has incredible value. I could go down through here and continue to tell you the highlights that I would expect you would likely need to know about each one of these things. However, you can read on your own. But at the end of the day, so if you do transport a patient with a ventricular assist device, one of the things to know is you need to know how to manage it. So you can kind of skip right down to that part. Okay, so this is what I got. What do I do about that? I don't suspect you would get many questions, but you could get one. And but nonetheless, when you're cutting the device or when you're cutting clothes, if the patient's critical, be very careful not to cut these kinds of wires, these sorts of things. You would always keep batteries and the controller, close with the patient, and the caregiver and or the patient themselves is going to be your best resource because they have received training and the use of the device. All righty. And if the patient is in arrest, you would need to try to ask if this is a type of a device that chest compressions are needed in or not needed in. And family would likely know that. They will have a identification card. And then there's always VAD coordinators for each facility. There's actually a number that we have in our protocol books here for anybody in the, Nashville, greater Nashville area that you can call into. You can tell them what the device looks like, get any kind of information off of it. They can tell you exactly what to do with it. So, but nonetheless, that's going to be rare. We won't spend a lot of time on that. Then we'll go down to stroke under cardiovascular. This is all of the American Heart Association stuff. Again, cardiovascular section is all of the American Heart Association stuff. Even though a lot of AHA material is involved in the other sections, this is where its big pushes are. So again, you would, we talked about earlier of how, when, and you would withhold oxygen, when you would give oxygen. This is just talking about the recognition. It will also discuss the ruling out mimics of stroke, such as hypoglycemia, and how you would need to assess and treat that. All right. And it talks about the different variations of the stroke assessment tools. Here's what I want to park on here. And right here, Roman numeral number 2 in the blue writing, these are links that take you to this information. I'm going to focus on the subpoints number 1 and 2. So number 1, Cincinnati Pre-Hospital Stroke Scale. Any of these focus basically on speech, arm movement, and facial symmetry. Any of these that are like fast type stroke scale, stroke assessments are based off of those things. The Cincinnati Pre-Hospital Stroke Scale is no different. It is the go-to that we would use for the rapid identification, rapid assessment to determine if it's a likely stroke or not. The Los Angeles Pre-Hospital Stroke Screen is the one that leads you down the path of, is the patient a candidate for the fibroanalytics or the clot buster. The Miami Emergency Neurological Deficit Checklist is known as the MEND exam. It's developed by the University of Miami, and it is more of a focused assessment. So if you are on scene, the focus in a stroke patient needs to be diesel fuel or gas, whatever. It needs to be rapid, safe and expeditious transport of the patient to a stroke center or a place capable of getting TPA. Now, based upon what somebody who would be familiar with the second one might know, they may have what's known as a large vessel occlusion, and they may need to go somewhere where they can have endovascular therapy. which is clot retrieval. But do not pick the MEND exam, the Miami Emergency Neurological Deficits exam, as something that would be done on scene. The only time that might ever be done, if you were familiar in it, and you should be, but you may not be, is if you were already moving to the hospital, and it would be a part of your focused, detailed exam or your secondary assessment. It is not something that would happen in the primary assessment on scene. What you would do on scene to, within 30 seconds or less, identify that, yes, I think they're having a stroke, an ischemic stroke, would be the Cincinnati Pre-Hospital Stroke Scale. All right, so all that being said, the management of stroke patients, again, this is talking about high levels of oxygen produce free radicals. So you would want to avoid. So it says, consider 2 liters of oxygen via nasal cannula instead of high flow O2 face mask. So picking the answer that said non-rebreather on a stroke patient would be the incorrect answer. And it clearly identifies that right here. And it tells why, because high levels of oxygen produce free radicals. It can do further damage to an ischemic penumbra, which is the area of infarcting tissue. Rapid transport to an appropriate receiving facility. All right. Some strokes are treated with TPA, which has a limited therapeutic window. What is that time frame?
15 to 30 minutes.
Well, what we're looking at is historically, this has always been taught 3-hour window, but some of the newer standards are actually about 4.5 hours. A comprehensive stroke center, such as locally our Vanderbilt, Skyline, those types of places, possibly within a 6-hour period of time. So, but the general go-to answer there is 3 hours, even though more and more leading industry standard text is saying 4 to 5. 3 to 6, depending on facility capability, is what it is stated now according to AHA. Either way, this is why that's fairly vague right here. So being as it's vague, I don't believe they'll ask you a specific number of hours on time frame. So again, angioplasty and stenting, this is endovascular interventions. In other words, clot retrievals, similar to what they do in a cath lab for the heart. All right, here you go, clot extraction. It's got that covered. Then it goes in cardiovascular down to cardiac arrest. 5 links in the chain of survival. Again, here we would need to current techniques of 1 rescuer CPR, 2 rescuer CPR, and the current techniques of 1 and I think it's in, or describe and then demonstrate. So you just need to know CPR, and which I hope that you've got that down by now. Something that you may not have down yet is earlier we talked about neonates. Any infant less than 30 days old, 1 month of age. And in neonate cardiac arrest, be it an immediate postpartum resuscitation or at any point in that first 30 days of life, the way in which you would do that is not the 15 to 2 or 30 to 2 if you were by yourself that you would do in normal pediatric chest compressions. It is 3 to 1. 3 compressions to 1 breath. Squeeze, 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 puff, squeeze, 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 puff. And the preferred method would be utilizing, again, if there's more than 1 rescuer, the encircling hands 2-thumb technique on the baby. All right. But again, 3 to 1, 3 compression to 1 breath. It's a very small little puff of air. All right, it doesn't take much at all. You would not want to give too much. All right, so optimizing your chest compressions, the rate is 100 to 120 a minute. You want to compress at a depth of at least 2 inches. All right, Minimize interruptions. Right here it talks about your ventilation and compression ratios. Again, 1 breath every 6 seconds, if with continuous compressions happening if an advanced airway is present. Again, endotracheal intubation, King airway placement, and so forth. Supraglottics, those sorts of things. Each breath should go in over about 1 second and ventilate with enough volume to observe chest rise. All right. High performance CPR, function as a team, and then also it needs to be coordinated every 2 minutes or every 5 cycles. You should rotate compressors. Mechanical CPR devices, you simply need to know this. They are not any better than manual compressions. If anything, manual compressions are actually preferred, according to the AHA. However, the time and the place for using these would be in prolonged periods of time where CPR is necessary, and if they can be applied to the patient and done so without creating an interruption in compressions, then excellent. They would also be good in transport. So we're not trying to stand up. It enhances our safety by utilizing the device versus trying to stand up and do CPR on somebody in a moving ambulance. It pretty much says it right there. May be challenging or dangerous for the provider and an ambulance during transport. So there you go. All right. Pediatric cardiac arrest. In the infant, 2 fingers just below the the nipple line, 2 fingers there. And then in children, so a pediatric patient, 1 year old or greater, you're doing 1 hand, lower half of the sternum, whereas in the older child or an adult, 2 hands, lower half of the sternum. Y'all know this information. All righty, y'all got this. All right. But you better make sure that you do understand it. And so the depth of compressions in pediatric patients is going to be 1/3 to 1/2 the depth of the chest from anterior to posterior. It says it right here. It says, so according to the NREMT, it's going off of 1/3 the depth. So from anterior to posterior, about 1/3 of the depth right there is what you're wanting to go off of. All right. And then the different techniques for 2 rescuer and so forth. All right, you better know that information. All right, and then it gets into acute coronary syndrome or ACS. This is so MI, STEMI, those sorts of things. You need to know where the ECG leads go. It is not scope of practice appropriate to interpret an ECG. However, it is scope of practice appropriate to acquire and maybe transmit the ECG to a receiving facility. This is why it's asking what you think is paramedic level stuff. But the role of the EMT or the AEMT especially is to anticipate what the paramedic needs to do next to provide the highest quality of care for the patient. Hence the reason that you need to know how to apply this equipment. All right. So if you don't know this and you're not familiar, then you need to study it. All righty. And it says that we need to show different examples of a 12 lead. So you know kind of what it means with different area of the heart, as far as what's inferior, what's lateral, what is an anterior MI, those sorts of things. That's easy peasy, lemon squeezy. We'll take care of that. Then it gets into a whole nother section of trauma. We're going to hold there. Remember earlier though, what did I say? Anywhere where you see a link is something you really need to know, because that's exactly where they took information and that's where they got the answers of something they're going to ask you. We talked earlier, didn't we, in just general discussion about the CDC 2011 guideline for the field triage of injured patients. This is different than the triage of mass casualty incident patients. All right. So, and again, I told you that there were 4 primary areas. You had so the area that they're injured in, the mechanism, the vital signs and physiologic findings, and then special considerations that you would look at. And this is all be reasons that they would go to the highest level of trauma center in your system. All righty. So these are the special considerations. This is all straight off of this document. So you don't even have to click it because they've laid it out here for you. You just need to review this and this information that we will share. For those of you who are joining us virtually, the best way to do this is in the chat box. You need to put your emails in, and so that way we can send a link out to send the information out. And then the folks that I have in class today, I'll have you write your email and your name down before you leave. And then those who are here today who need a retest letter, and you need to hang out with me today until I can print that and hand it to you. I don't want to have to do, 2 or 3 weeks from now, I'll be trying to worry about getting you a letter. So you'll leave with it today. And then also what we'll do is we send that to our state EMS Region 5 coordinator or consultant. And regardless of what part of the state you work in, he'll send that to the registry for you. So when you get done with this today, that's what we'll do. All right, moving on. So I see that my audio is working. The old chat box is filling up with emails. And then we can pull those later when we have time, as soon as this is done, and begin sending you these links. One of the links is exactly, well, one of it will be if you're EMTB, here's your link. If you're AEMT, here's your link. The only difference is the version of this on the registry you would look at. The AHA thing is going to be the same. And then I'll attach my I got some other PowerPoint information with you. So this goes into trauma. But before we go into trauma, let's change gears, because if you keep doing the same thing for too long, you bore people to death. And even though you may be learning something, your mind can only absorb so much of a good thing at one time. So we've got to change gears a little bit. So I'm going back to my crowd here. Those who are on our virtual guests, we're swapping gears. We're going over to look at a document that our colleagues in the room have in front of them, and now you will have it in front of you. This version has the answers already on it. So when you go through and we watch this later, from the recording, or if you are trying to make notes now, there they are. For those of you who are sitting here, particularly those who will be needing the retest letter, this is something that I would need to keep a copy of before giving out the retest letter. So what we will do is we're going to just take a quick review down the list. And then anything we see, then we're going to talk about it. So what is the compression to ventilation ratio for 2-person CPR on an infant? It's 15:2, right? If you're by yourself, it's 30:2. Everything for adult is 30:2. Now all these stuff change when you get a secure airway in place, right? All right. But just ventilation to compression without a secured airway, that's what we're looking at. Now, again, if it's a baby and it's less than 30 days old, then it goes to ratio of 3:1. So we're going to change this, excuse me. We're going to change this and say 1 to 1,000, because this is the EMT, AEMT version. And the max, the adult dose, will go with 0.3. Actually, because of various texts, we will say 0.3 to 0.5. If you don't know and it doesn't specify, stick with this one right here. That's our Tennessee guidelines. But on a national level, a lot of techs will allow you to go up to 0.5. Guy my size, for example, well, you can give me 0.5 and it ain't gonna hurt nothing. All right. You just got to understand, my friends, if so for basic, you're going to be utilizing an EpiPen. For AEMT on the national level, you would be drawing it up manually and doing a manual injection intramuscular IM epi. The number one cause of death and anaphylaxis, that is extremis, anaphylactic shock, is the untimely administration of epi. So you also need to understand this. There are two types of EpiPens. There's EpiPen Junior and regular EpiPens. A regular EpiPen is going to give you 0.3. An EpiPen Junior is going to give you 0.15, half of the big one. So AEMTs, you're worried about having to do a calculation and having to draw it up. Any patient who's going to be a kindergartner or less, and the reason I'm basing that is because in pediatrics, about every 1 year of age, 75th percentile is about 10 pounds. So when we go into kindergarten as humans or as people, about what age are we? We're about 5 to 6 years old. So you're looking at, so when you get over that 60-pound range, you're into the adult dose of 0.3. So an 8-year-old, 7-year-olds, they're and above, they're going to automatically get that 0.3 all the way up to adult. If in 5 minutes they're no better, they get it again, if you have it available. All right, so the point is, if you're taking your test and it tells you that you're giving this to a 2-year-old who weighs blah, 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 yeah, look for the answer on the test that says 0.15. All right, and it needs to be right there close to that, if not that, because that's what they're going to get if a basic's giving them an EpiPen. So what is the real difference in an AEMT giving it? Do you see what I'm saying? And so that's what you don't let that confuse you and drag you off in the land of confusion and making you miss a question, because it's a very simple thing to do. And it has to be simple because it has to be done quickly. All right, we will come to this, but the biggest thing there is recognizing the need for it. So here in a moment, we'll come to the signs and symptoms of anaphylaxis. All righty, some of the various uses of epi in treating a pediatric patient. Epi is used a lot in sick medical pediatric patients. So if I were giving epi 1 to 10 via IV, is that your scope of practice? If I were giving it for bradycardia or cardiac arrest in 1 to 10, that's not your scope of practice? Okay. Well, what would you be? So if I said, will you get out the epi, what color box is it? Purple. So purple's the atropine. So great answer, because you've got to be bold enough to throw an answer out there. It's like a tan color. It is. It's a tan color. It's a beige color. All righty. I have one on the other side of that door. I'm glad to show. Why is that even important? It's important because you are able to stay a step ahead of the game to prepare and assist the paramedic partner with what is in their scope of practice. But let's go on down. Did you know that you can put epi in a nebulizer like you would albuterol? Now, albuterol in a nebulizer is your scope of practice, but epi is not. But you know what is? Putting saline down in there to create cool humidified air for a child with epiglottitis or croup. Then the paramedic would add the epi to that. So what do you need to do as the EMT or the AEMT first? You need to put the saline in there for them, because they can't put just epi down it. They need to have the saline in there first, then they can add the epi, and that shrinks up that airway tissue. So again, can be used for that. Now, what about epi-IM for anaphylaxis? Is that your scope of practice? Absolutely. Some of the teachings and some of the texts may have said sub-Q, and that's also accepted. That is your scope of practice. But understand that IM is going to be a little faster than sub-Q. So if the patient is so bad they need the shot, I think they need it quick, don't you? That's the reason we're giving it IM. What if I said that you could also give it IM or sub-Q in pediatrics for asthma? Is that your scope of practice? It's not. So that is paramedic scope of practice. So AEMTs and EMT basics using an EpiPen and an AEMT drawing up IM Epi 1 to 1,000 for anaphylaxis is accepted scope of practice. The exact same thing is done in asthma if it is a bad case of asthma, but that's only paramedic. So you need to understand that line there. When is it accepted for you to when do you need to be helping prepare it for the paramedic to do? All right. So what is the most common cause, so number 4, of bradycardia in a pediatric patient? Hypoxia. There is a difference between hypoxia and hypoxemia. Hypoxia is when the oxygen sat gets below 95. Hypoxemia is when the oxygen sat gets below 85. They ain't going to die or have brain damage just because their oxygen is less than 95. They're not. They will begin the process of dying and developing brain damage when the oxygen level is less than 85. Hypoxia is a low level of oxygen in the bloodstream. Hypoxemia means now there is a low level of oxygen at the cellular level going to the tissues. These tissues make up the organs. The one most susceptible to all of these being the brain. So, anoxia is when the CO2 is greater than 45 millimeters of mercury. So that's the high, that's one, so the CO2. Anoxemia, when they're actually suffering possible brain damage from having respiratory acidosis or a high CO2, is when the CO2 is greater than 60. That is no longer anoxia, that is full-on anoxemia. They are having a dangerous CO2 level at the cellular level. And what does that cause? That causes oxygen to no longer be able to unload and offload with the hemoglobin protein in the blood. So in pediatric patients, hypoxia is the most common cause of bradycardia. So a bradycardic pediatric patient needs to be what? And it'd be bagged with 100% O2. Then when you get them better, you can maintain them with a non-rebreather maybe. But first and foremost, they need to be bagged. Did y'all know that seizures aren't really, their seizure really won't kill the kid? A pediatric patient having a severe seizure. This is disordered control of breathing. The point here is the seizure ain't what's going to kill them. The seizure causes a breathing problem, and the breathing problem causes hypoxia, and hypoxia causes bradycardia, and bradycardia causes cardiovascular collapse. They go into what's called a bradyasystolic arrest. And in the meantime, once that oxygen level gets below 85 and the CO2 level rises, the respiratory acidosis due to the hypoventilation, the CO2 gets above 60 and O2 gets below 85. Well, now the child is having an anoxic injury from the hypoventilation due to the seizure. A lot of these seizure children will live, but they've sustained anoxic injuries due. So a seizure patient, a severe seizure patient, your focus is maintaining the airway and making sure air is moving. All righty. Do not ever hesitate to bag or pick assist ventilations and manage the airway on a critical seizure patient. That's probably the right answer. And in the field, in reality, it's probably the right action to take. If it crosses your mind, it's crossing your mind for a reason, and you need to probably do it. All right, fair enough. Moving on, let's go to the next thing. Number 5, earlier we said there's one thing that differentiates respiratory distress versus respiratory failure, and that was altered mental status. Well, here, and that's going to be actually number 6, is re-emphasizing that same question. But number 5 emphasizes that there's one simple finding that separates compensated shock from decompensated shock, and that is low blood pressure, hypotension. You need to understand what is hypotension for what patient. So a normal healthy adult, anything less than 100 systolic, boom, decompensated shock. An adult who has a history of high blood pressure and takes meds, unfortunately, fat 40, 22 years in EMS, I wear that badge now, unfortunately, of hypertension. So for me, anything less than 120 now is going to be a red flag. Especially the older patient who's been on those pills for a long time. If I lost some weight, probably exercised and quit stressing over everything, trying to do too much at once, it probably helped me. But you see what I'm saying? The patient who's on blood pressure pills, for them, anything less than 120 is kind of a red flag. And in pediatrics, anything less than 70 plus 2 times their age in years. So 70 plus 2 times their age in years. If their systolic is less than what that is, then that's decompensated shock. All right, so hypotension identifies, so because shock looks like respiratory distress. By looking at them, you can't tell if they're in failure or arrest unless you see something with their mental status. You know, they're short of breath, that looks the same, you know what I'm saying? Shock looks the same, skin color and condition changes. It looks the same, but it's the presence or not of hypotension that differentiates that. All right, we already talked about number 6. Again, respiratory distress versus failure, altered mental status. Understand that CPAP is your scope of practice as an AEMT. EMTB, they're not going to worry you about CPAP. AEMT, you're going to need no CPAP. Continuous positive airway pressure, CPAP, is not an option for a respiratory failure patient. It's only used in distress. Only if they are still oriented. If they have went beyond the point of being well oriented and they now have altered mental status, that's hypoxia until proven otherwise. You don't need CPAP, you need a bag valve mask to assist their ventilations. You may be able to turn them around and then you can maintain them on CPAP, but until they're again well oriented, you can't. Make sense? All right. Number 7, we already talked about that. How would you prepare a nebulized epi? How would you prepare to give it? So for AEMTs, you know that the paramedic partner needs to be treating croup or epiglottitis. Put some sterile water, some normal saline in a nebulizer and run it like a breathing treatment. Go from there. Very good. Number 8, waveform capnography. What would you expect to see if your pediatric patient was hypoventilating? Say it again. 45. So yeah, 45. Yeah. If they were hypoventilating. Yeah, if they were hypoventilating, that would mean they would be in respiratory acidosis. So their CO2 would be high. And so it would be a reading, so capnometry, which is a numeric reading, which is known as quantitative capnography, would be 45 or greater. The more severe the respiratory acidosis, then the higher the number would go. If you were looking at the waveform of capnography on a uh, capnography reading, then you would see what looks like shark fin type waveform, possibly. That could be bronchospasm. Either way, if it's not bronchospasm, your graph would be very high. It would be very high, indicating that high number. And this is respiratory acidosis. It says, I really should do a video on this subject. Well, I have that. It's on YouTube, and I got a whole spiel about capnography on there. It was one we made a long time ago, but nonetheless. Number 9. Don't worry about this. This says, what is the pediatric dose of Versed? Here's what I want you to know as an AEMT or an EMT basic. If your paramedic partner or a doctor has treated a patient with a benzodiazepine, a sedative, Valium, Versed, Ativan, whichever one of these they choose from. Generic names, lorazepam, midazolam, diazepam. Hell, it sounds like some kind of a cool song. But it's like, but nonetheless, here's what you need to know is the seizure itself can cause disordered control of breathing where you need to bag the patient. But the patient can also have disordered control of breathing after these meds stop the seizure. These are sedating medications. They sedate the brain to make the seizure activity stop, but they also suppress respirations too. So be prepared to assist the patient with their breathing before and after they have been treated by the paramedic. As paramedics, we typically complicate things. There are a few things that we're useful for, but 90% or more of what saves people's lives in all reality can be done by an EMR. And then it gets a little easier if you're a basic and a lot easier if you're an advanced EMT. When you become a paramedic, you start complicating things or forgetting where you need to start at. I'm not here to debunk paramedics. I'm just carrying on. But I think there's some truth in that. Any decent paramedic better make sure they're a great AEMT first, and they better be an excellent basic. All right. So why is this important to tell you? Because if you're sitting here preparing to take the test as an AEMT, if you ain't short up on the basic stuff, then you ain't got no business trying to do the advanced. And the majority of what we're talking about with some of this information is basic knowledge. So you better make sure you're short up on being an EMTB before you go try to be an AEMT. The majority of the questions are probably your old level of licensure that are stumping you. Most paramedics, you know what kind of questions they miss on the test? EMR level knowledge. You know why? Because they spent all their time studying for the dosage of calcium chloride and how to do a drip of a vasopressor and how to interpret a lateral anterior MI and leads 1, 2, and vectors 5 and 6. They spent all their time thinking on this 30, this 50-foot elevation level, and the questions they missing are down here where they started. And they have failed to keep up with industry standards on day one. So enough about this. Moving on, number 10. Oh, look, I quit putting answers on it right here. I got lazy. Imagine that. So we already talked about number 10 at extent, but I cannot harp about this one big enough. Number 10, describe the treatments needed for a pediatric patient who is actively seizing and exhibits cyanosis with bradycardia. As a training officer who oversees the clinical operations of a large service, more than once, before I came here, I was a training officer of another service in this region. And at that same time, taught at one of the academies of one of our largest agencies in the state. More than once in my career, I have seen good paramedics spend a 20-minute transport with a critical seizing pediatric patient, spend the entire time fooling around trying to get an IV. The whole time the child's O2 sats are getting lower and their EtCO2 or their capnography or their CO2 levels are getting higher. They're getting closer and closer and closer to an anoxemic injury of the brain. And yet they are focused on trying to get an IV. You know, why they want an IV? Or they may be trying to get their partner to get the IV. We need to get an IV. We need to get an IV. Gotta have an IV. Oh, Lord. Because they think that they need to stop the seizure. I ain't worried about the seizure right now. I'm worried about what the seizure will cause that is going to kill the kid. The hypoxia. So priority number one, regardless of what level of licensure you are, maintain airway and assist ventilations as needed. I need to keep that little airway in a sniffing position. Straightens out the trachea. I need to assist those ventilations if necessary with a bag valve mask. If you ain't sure, then you need to do it you need to give them. All right, you'd be better off to give them and they did need them because you ain't gonna hurt them versus not giving them and they did need them. I guarantee you they're going to have a little bit of respiratory acidosis. The most common cause of respiratory acidosis due to hypoventilation in a pediatric patient would be seizures, status epilepticus. All right, everybody heard that? The second, and so the most common cause of seizures, so we know what the seizures cause, but what causes the seizure? Fevers is the most common, and then the second leading cause of seizures is low sodium levels. Hyponatremia, a low sodium level. How in the world does a pediatric patient, a little old 2-year-old, develop hyponatremia? I can see that happening in a nursing home patient who's on TPN and their regimen's off or the insurance or whatever got screwed up or the pharmacy. I could see this happening. That'd be unlikely. That'd be some negligent care, but we've seen that. So you take a pediatric patient who's had 96 hours of diarrhea and vomiting. Not only will that child become dehydrated, but they will also lose electrolytes. And when they lose electrolytes, key electrolytes, sodium and potassium, have to come together, and then mag and calcium need to come. So these electrolytes is a big deal. And children, but you take a baby. Did you know that in a socioeconomically challenged family, and what I mean here is this is an appropriate word for saying poor. Back where I'm from, some of my peoples, we run into this all the time. Family, they having a hard time. It ain't necessarily because they're out here spending all their money on beer and cigarettes and tattoos. In a stereotypical world, unfortunately, a lot of times that's what we think in our minds, but the reality is they may be doing the best they can, and they're trying to keep the heat turned on, and they're trying to buy a few groceries, and they got to pay rent or they're going to be kicked out. They don't get paid again till Thursday, and it's Monday. And the mama she got 2 bottles of formula left to feed this baby for the next 3 to 4 days. What's she going to do to try to get through? That's all she's got. She's going to mix it with water. Now, what happens? Well, we still get to make bottles, but the bottles that the baby's taking in for the next 72 to 96 hours now contain only half of the nutritional intake that the child was getting. So what happens? Due to that being cut with water, the sodium level is no longer there. And so the child develops hyponatremia. And that is the second leading cause of seizures in young pediatric patients. And when it happens, those are the most terrible seizures you will ever treat. Are they not, Captain or Chief Ensign?
That's correct.
That's right. That's right. So the child who's experiencing a hyponatremic seizure will have a terrible seizure, and they almost every time I've ever seen it, they develop respiratory acidosis, hypoventilation, anoxemic injury. So I can't emphasize enough about picking the answer that says, first and foremost, let's keep them from getting anoxic. Then we'll treat the seizure. Then the next thing we'll do is treat the underlying cause of the seizure. Everybody wants to try to put them in some cool water and cool them down. That's the reason they're having a seizure. We'll treat that later. And then we'll treat the seizure itself with sedation and type beds that a paramedic give later. The thing I need to fix right now is the anoxemic injury threat. So I need to make sure I bag them. Everybody got me on that? All right, cool. Number 11, how would you treat a school-aged child who is in extremis from asthma? What does extremis mean? Extremis, yes.
Assist them with their inhaler.
All right, yes, you would. You would assist them with their inhaler as a basic. As an AEMT, what else could you do? Or what would be your scope of practice? To deliver albuterol breathing treatment, right? A bronchodilator, a beta agonist medication. The beta effect here that I'm looking for would be bronchodilation. What would that look like on waveform capnography? Miss Lord, what do you think it looked like on waveform capnography? Shark fin waveform. It would look like a triangle versus a box-like shape. That means a bronchospasm. All right, that means that the patient needs a beta agonist medication to help bronchospasm, a bronchodilator. All right, this being said, so what you would do, basics, you could assist them with their prescribed inhaler. If you couldn't do that, first thing you could do would put high flow oxygen on them. Then you could assist them with their inhaler and you put the high flow oxygen back on. AEMTs, you would be giving them the nebulized breathing treatment through the inhaler. So they're getting supplemental O2 and the beta agonist medication in the same thing. Then AEMTs, what you need to do next would be work on establishing an IV. IV would not come before the beta agonist medication, only after. Why would you need the IV? Because again, the role of the AEMT is not only to do everything you would as an EMR and an EMTB, but now prepare to assist the paramedic in those next steps and have an idea of what they are. Well, the reason you'd need that IV, the kid don't need fluids. He may need steroids. He may need a magnesium sulfate drip. And before long, they may end up giving him an IM-EPI shot like we talked about a while ago, which IM-EPI is in your scope of practice for what? What condition? Anaphylaxis. Paramedic can also give it for cases of extremis after albuterol has been given in pediatric asthma patients. All right, so this is why you want to stay a step ahead of what's next. How would you, all right, we'll come to, let's see, the next thing. What is the pediatric dextrose dosage in pediatric patients? The dosage for dextrose in children, peds. Is it D10 or is it D50 or is it D25? All right, write this down. And our folks joining us virtually, write this down. I have it in a PowerPoint, but if we just go through our questions here, it's actually more informative and more interactive, I believe. D10, here's where you would use D10. Now, technically you can use D10 for everybody, but the reason we sometimes don't use D10 for adults is because it takes so much of it in them. It takes so long if they're already at a critically hypoglycemic level, one in which the brain is no longer getting the glucose that it needs. it has to have oxygen and glucose to maintain aerobic metabolism. Without oxygen and glucose in a quick-like, readily available form, cells in the body turn cannibalistic and they develop anaerobic metabolism. So to maintain aerobic metabolism, you got to have oxygen and glucose. Those are the two sources of fuel for normal metabolism, aerobic metabolism, homeostasis. So therefore, you need to, that's why we try to get it in them as quickly as possible. I know that some protocols out there now give D10 for everybody, but on a national spectrum, what we're going off of here is a national standard as follows, straight out of PALS, as follows. D10 would be given to the patient that is 0 to 6 months of age. So the infant patient, neonates and infants who are 0 to 6 months of age. D25 is recommended for patients who are 6 months to 8 years of age. D50 is safe to be given to patients greater than 8 years of age. The dose on D50, the dosage would be 1 to 2 milliliters per kilogram of body weight. 1 to 2 milliliters per kilogram of body weight. On D10 and D25, they are less concentrated. And so because they're less concentrated, you got to give a little more of it. So it's 2 to 4 milliliters per kilogram of body weight. Again, D10 and D25 is 2 to 4 milliliters per kilogram of body weight. And again, as a recap, your D50 and the child that would be greater than 8 years of age would be 1 to 2 milliliters per kilogram. Now, there are 2 reasons that little patients need little dextrose. Those 2 reasons are as follows. Number 1 is dextrose can be caustic at the site of venipuncture, where the IV needle goes into the vein. And the reason being is because it has, if you look at it under a microscope, it looks like a little river full of tiny little icebergs. And you know what an iceberg did to the side of the Titanic, and it was a vessel. So you can only imagine what tiny little icebergs are floating through on the inside of the blood vessel may do. They can lacerate and scrape and tear away tissue and can risk extravasation. They can cause it to blow. So a tiny little fragile vein, such as a 22 gauge or a 24 gauge that you would see in a pediatric patient or a young pediatric patients, you would either treat them, those little fragile veins, you can't put, if you go to put high concentration of dextrose through there, they're going to blow. And when they blow, dextrose outside of the vein is very necrotic to tissue. And these patients can suffer incredible tissue damage to the point of, there are cases out there where people have lost extremities from extravasation or infiltration, or when a line blows and it contains dextrose leaked out. So the smaller the patient, the smaller their blood vessel. The smaller the IV you're going to have, then the smaller the dextrose you need. Hence the reason we have the D10 for this group, the D25 for that group, and D50 for the rest of them. Now you got a 9-year-old, you probably got a 20 or an 18 sunk off in there. And in that situation, then you can afford a D50 or better. The second and most important reason, and then I want you to meet somebody. The second and most important reason that we use small dextrose in small patients is because dextrose in its higher concentrations, such as D50, is hypertonic. Do you remember your discussions in AEMT class? For those who are testing as AEMTs, this is why it was important for you to learn hypertonicity, hypotonicity, osmosis, diffusion, all those words. D50 is hypertonic, meaning that it will pull fluid in the wrong direction. And so in other words, not to get too awful deep in these weeds, I'd love to, but we won't due to time. If you slam D50 on a little bitty pediatric patient, it'll fix their sugar, no problem. But in about 20 minutes, maybe even less, they'll start developing intracranial pressure, ICP. They'll begin to have mental status changes, possibly seizing, these sorts of things. Why? Because you are making the brain, you're making swelling in the brain. You're shrinking down the brain tissue and taking all the plasma, the water content that was inside the blood vessels, inside the brain, and drawing it out and putting it to the outside. And it's squeezing and shrinking the brain in and creating an undue amount of pressure up here. So they'll start having signs of Cushing's phenomenon, seizure activity, these sorts of things. So this is why you have to be careful with that. All righty. D10 is actually hypotonic. So D25, just a touch hyper. But for these patients, the adult patient and the adult brain can absorb the higher concentration just fine. Whereas the pediatric, small, tiny pediatric patient cannot. All right, is Chief still out there? Yeah. He went that way. He's like a poot in the wind. He's hard to keep up with. So anyhow, Chief Henson, what do you have to add about that? And so the AHA, before I move, another option that would be a correct answer. So what I told you, those dose ranges for dextrose are the milliliter based versions of D10, D25, D50. The AHA textbook answer for any concentration you choose is actually 0.5 to 1 gram per kilogram. So write that down because that could also be a correct answer that you may run into. Cam's in the back of the room. It's showing everything up front, as you see here. And audio's up with the mic over here. You want to come say a few words to our guests, Chief?
Sure.
Guess this is Chief Greg Miller. He's our Director and Chief of Sundry EMS. Just wants to welcome you here.
Good morning. How is everybody? This has become a very successful program that Chief Dyer does. And I always like to just take a few seconds and slide in here and give some advice and words of wisdom because I'm very familiar with what you're doing. So I taught at the college level for 10 years and I taught several EMT and paramedic classes. So I know a thing or two about preparing people to take National Registry. And the first thing, and I'm sure Brent has already given this example, but the first thing you got to realize is there's nothing wrong with you. This is a unique test. And if you've taken it 2, 3, 4 times, that doesn't mean, number one, that you're dumb. It absolutely does not mean that. It's like a mystery and you got to figure out how to crack the code. Okay. And he has some very good tips and techniques for understanding that. And I have some that I have given my students as well. How many of you feel like that just in general, you're not a good test taker? So most people will find themselves, yep, that's me. I'm not a good test taker. I just get anxious and your mind starts wandering and you start worrying. How many of you, when you've taken this test, if you've taken this test before, find yourself worrying about the time limit and find yourselves trying to rush, or at least in the back half of the exam, you try to rush. So again, don't do that. Studies have shown that you've got plenty of time to do it. It's Very, very few people have ever had the exam time out. And you will have an opportunity to do that. Get used to reading the question. It depends on where you're at as your level of reading comprehension. Okay. If you're the kind of person that messes up words when you read, okay, you forget little bitty words out of that question that makes a difference, like all of the following except. What's the key word in that question is except. That means you got to find one that doesn't fit, or which is not true, things like that. So be very slow and methodical when you read it. So you're reading it looking for those odd words, except, or all, or never. Those are the ones that will get you, because you'll look and your brain misses that word. And then your mind, when you read the question choices, will automatically go to the one that you think is right without that. You change that word. How many times have you missed a question? We've all missed a question in our life that had all or never or except. And we went back and read it. It was like, oh, I missed it. It said except. So a way to do that is, this may work for you. It may not. But I used to tell my students that read your answer choices first and then read the question. Because you're almost painting yourself a picture of, okay, here's an answer, here's an answer, here's an answer. You're formulating in your mind what question would go with those answers. So again, see if that's something that works with what Chief Dyer is saying. And then a lot of that is realizing that when you got out of school, a lot of you studied the most advanced stuff you could find. And what do people most commonly fail? What sections do they most commonly fail? The basic stuff. EMS operations is one of the most commonly failed. So you're reading this advanced level stuff. Man, I got to get this. And the way these test questions are written, it's written based on a functional analysis of the profession. So you get test writers, you get question writers, people like me, that we write questions and we send in, and they say, okay, and they add that to the bank. And also realize that you're going to find questions on this test that you don't know the answer to. There's going to be beta questions. So a lot of the questions that you may answer aren't even counted against you, or aren't counted at all, because it's a beta question, meaning it's there to get some data to see how everybody answers it. And it might be a very, very tough question. It might be a question that you have never, ever heard of in your life. I've had people call me going, it's asking me stuff that I've never even seen in my book. Well, more than likely, that's a beta question. But here's what people do. That's stuck in your mind. And whether you realize it or not, you're still stuck in that rut where that question got you. Because you are answering a question and it was hard. And you were going, oh my gosh, here we go again. I don't know the answer to this question. I'm going to fail this attempt. It's going to be a bad day. Why don't I remember that? And then you answer it and you click to the next one, but your mind is still thinking about that last question. And you're not given 100% of thought to reading this question. You got to have amnesia. You got to forget what you just answered. Okay, let me take a deep breath and let me go again. Does that make sense? Because it has affected you all. Some of these tough questions, it's affected you so bad that you came back and you said, it asked me about this, and you remembered it, and you held on to it for 2 or 3 questions later, and come to find out it's probably not even going to count. It's probably a beta question. It's there just to get some data and see how people do on it. So, you're not going to, I don't know that it's even feasible, unless you're a genius, for someone to go in there and ace this exam. It's not the type of exam that people make 100 on, okay? So you're going to find a question that you don't know the answer to. Don't let it ruin your day. Okay. Forget about it and move on. Say, okay. Because one question, even if it's not a beta question, is not going to make or break you. Okay. Can I answer any questions for you? All right. Yes, sir.
Questions in regards to, I was going to ask very well, questions that separate the difference between, and I don't understand between understanding your scope of practice, but with setting up something for a medic, for knowing what a medic is supposed to do versus what we can do on our own. That makes sense.
Okay, so he's asking, are you asking me what is the difference in a question that may be talking about?
Prepping and prepping something for a medic.
So being a partner and getting stuff ready for your paramedic partner. Have you all seen some of those questions?
Yeah, I think I've seen something in regards to ET tube and
Okay. So any of that stuff where it's just general knowledge for you, where you're not expected to perform the skill because it's not within your scope of practice, but you might be expected to be an assistant, is where he's going with that, then you need to have basic level, entry level familiarity with that equipment. Okay. So you ought to be, as an EMT, as an AEMT, you ought to be able to pick up an ET tube. You ought to be able to identify the landmarks. You ought to be able to know that the 15mm adapter is the piece at the end that the BVM hooks to. You ought to be able to know that the Murphy's eye is the distal eye at the end of that ET tube. That way, if the beveled end of the tube becomes occluded with a mucus plug or comes up against, that's there also to where the oxygen can still come in and out. If it becomes occluded, you ought to know where the centimeter markings and what they are there for, where the pilot cuff integrates into, and the difference between a cuffed and an uncuffed tube. That basic level stuff is what you ought to know. You shouldn't see questions on there that ask you about what to do if there are signs and symptoms of a displaced tube. That paramedic level stuff shouldn't be on there. But again, if it's a beta, rules are somewhat off. And then, that's where you'll go to the dope pneumonic. Anytime there's difficulty in ventilating a patient who has been intubated, then you need to go through the dope pneumonic, displacement obstruction, pneumothorax, and equipment failure, making sure that. But again, the stuff that you need to know on the paramedic prep stuff, the paramedic assistant stuff, should be straightforward out of your book. Okay. The notes on the sides, some of you all may not have picked up your textbook since class. Okay. That's not, in my opinion, a good thing, because I see a lot of guys that when they get out of school and they start trying to navigate and successfully pass this test, they live and die by online test generators. And why that gets you in the routine and the habit of answering questions, it doesn't refresh your cognitive base level. So don't be afraid to pick up that book, because now that you have learned a little bit, reading the italicized words and the bold text and the stuff that's in the margins, highlighting those and saying, okay, you might have gleaned over that your first semester of EMT school. You reread it now and it's going to make more sense. You might gather that. So I'm not saying go home and read the textbook cover to cover, but skim over that like you're look for those italicized words, those bold words. The beginning of every chapter has the objectives. Those objectives are what's used to write these tests. Those objectives are what's used to write this exam.
In the format, the outline we were showing you, remember before lesson content, it has the objectives as to what the instructor is supposed to teach. That's where it's coming from. Yeah, that is the big points. So, yeah.
So good question. Anybody else have a question? Y'all understand when I say the power of positive thinking? You know what I mean by that? Don't walk in to a Pearson Test Center, or don't walk into your room where you're going to take it on your own, because you can take it at home now, defeated. If you sit down and log in with the mentality of, well, here goes the 4th attempt, I might as well get ready to schedule my 5th, then if you go in defeated, your mind is not going to perform optimally, because you're already psyching yourself. It's psychological warfare. You're psyching yourself out of this exam. If I tell you a dozen times you're not going to be able to do something, and you begin to believe it, are you going to be able to do it? No. So you gotta wake up. You gotta eat a good breakfast. You've got to be ready to go. You can't stay up till 4 or 5 o'clock in the morning cramming to go take an exam at 7 or 8 o'clock. Nah. Study after study after study have shown that is counterintuitive, and it does not work. You've got to prepare for this like you're going to, if I told you you were going to get up and we were going to run a 5K or a 10K in the morning,
I'm out on that.
what are you going to do for the couple of days prior to that? You're going to rest. You're going to make sure that you're getting the appropriate nutrients and everything in. You need to do the same thing, because that's what this thing is doing. It's running a marathon for a couple of hours. Mm-hmm. You're putting more brain power into a one-seated session that may last 50 minutes. It may last 87 minutes than you normally do in a 24-hour period. And you've got to take care of that. I don't think that you should work the shift the day before, the night before, because if you're out taking care of everybody else's problems, you're not preparing for that. You need to flex that shift the night before. You need to relax, and then I'm big on buddy study, okay? Because you can read the same information yourself. If I asked each of you all to write a paper for me and turn it in the morning, you're going to reread over your same grammatical errors and not catch them. However, if you sat down with someone and you all just read questions back and forth and start doing some scenarios and say, okay, you were first on the scene of an MVA in which there was an unrestrained 16-year-old passenger who was ejected out of the windshield. What is your first steps? So you start asking that. Your buddy should be able to pick up on your errors. Where are you going to first? Because it's that first instinct that you're going to think, is that first instinct that you're going to click that answer. Mm-hmm. If you're not thinking about body substance isolation and scene safety and all that first, as you walk up and you're trying to get a windshield survey or whatever else, and you're immediately thinking, because I said something in the scenario that they're face down and they're not breathing, then you're not thinking right. So you got to rechannel those. If you're sitting there talking with a buddy and you say, well, I'm going to run in and I'm going to grab, well, maybe the answer is airway. But the answer might be airway because there's nothing mentioned about body substance isolation, about scene safety, about spinal precautions, about all those things that we know in real life we've got to do before we can just walk up to somebody and crank their airway open, right? Do I open the airway different from someone that's suspected trauma versus someone that's not? Yeah. So what is your first instinct when you answer these questions? If you're going to answer them, it's going to be the same verbally as it would you reading and clicking. Now, because I just said that, avoid the urge to click on the first answer that sounded right. Because the way they come up with the complexity of these test questions is they have to have so many sophisticated distractors within the question and within the answer choices. So I might read A, and A looks right. But I read B, and B is right because it added one thing. What if every one of those answer choices did that? And you come to A and went, it's A. But the very last one was the the best answer of all because it had all of the above. It had all the I's dotted and T's crossed and everything that could possibly go right was there. But you got in a hurry and you didn't read all of your choices. Resist the urge to go, oh, it's me. I know this one. I know this one. Because you will end up clicking it and you'll think, yes. You pat yourself on the back. I got that one. No, you didn't. Because D said all of the above.
That's true. That happens a lot, man.
There's a lot of people that miss 5, 6, 8, 10 questions just on that. And that is enough to cause you to fail one section. And that's all you have to fail in this exam because it is, an adaptive, computer adaptive testing. So, all right. Hey, thank you for trusting us. Thank you for trusting this guy. You're not broke. Okay. Trust me, you're not broke. You've passed this class. We've just got to get you in the right frame to answer the way they want them answered. And it's a game. There is nobody that has fussed and cussed and robust more about the National Register exam than I. I used to call them out to their face and say, listen, this is hogwash. You know, this is crazy. Yo, this is a money racket, blah, blah, blah. And I still believe a lot of that. But we can crack the code. All right. If you'll trust us and listen to us. Now, if you're going to come here and sit in this room for 8 hours and go home and then do the exact same thing that you've done for all of your previous attempts, you're wasting your time.
That's true.
You've got to change. What's the definition of insanity? Repeating the same process over and over, but expecting a different result. If you always do what you've always done, you're always going to get what you've always got. Today's the day to change it. Change your study habits, change your preparatory habits, change your thinking habits, instill what he's telling you to, and you'll make it work. But you can't just come in here and sit down and it's going to soak into you from us through osmosis, and then you're going to go pass the test. It won't work that way. If it could, we'd be making a lot of money off this class. We'd be charging for it. That's why it's set up to be free. Okay? Because we got to tap in for you to make the in-flight adjustment. All right. Any more questions?
Who in here is not working anywhere right now? All right.
Hey, we're hiring. We're always hiring.
Yeah.
Keep that in mind. We are the highest paid EMS agency in the state of Tennessee. So that's always a good thing to know too. So we got some pretty good equipment, pretty good facilities,
Questionable chief director.
pretty good people, you know.
We can work with that, you know.
That's right. Keep me good on all fronts. You got any questions, feel free to ask us.
We will hit a few more of these and then we'll kind of look at another break here. So, so we ended with number 12. Let's look at number 13. I heard Chief talking about this, and yeah, you're not the one doing the intubation, but everybody needs to know where to look on the tube and how to know how to prepare the tube to use. So how do you select, number 13, the ET tube size in a pediatric patient? Well, there's a couple ways. You can do this by looking on a Broslow tape. It will tell you. You could kind of judge the inner diameter of the pediatric patient's nair. You could look at the distal end of the pinky finger and kind of compare. You know, it looks, you know, be like, yeah, look about right. Or you can use a formula, 16 plus age in years divided by 4. 16 plus age in years divided by 4. Nowadays that we're carrying cuffed ET tubes on pediatric patients as a newer standard, and the National Registry even says use cuffed ET tubes on everybody except neonates. So any infant that it would be less than 30 days old, you're talking like 4.0 and below ET tubes, those should not be cuffed. We, however, carry them that are cuffed. And the reason we do that is I may not inflate them. I may not need to inflate them. But if I do need it later, it's there. I don't have to change that. So on a cuffed ET tube, it's 16 plus age in years divided by 3.5. 16 plus age and years divided by 3.5 is a way of determining tube size for a cuff tube pediatric patient. And again, according to the registry themselves, that is best practice, with the exception of neonates. And a term infant, a term newborn, a newborn that's been delivered with normal gestation will start at a 4.0 ET tube. The little bitty 2.5s and 3.0s and 3.52s are for like preemies. All righty. So the other thing is number 14, how would you determine the depth of insertion of the ET tube in a pediatric patient? Well, whatever size tube you had, you multiply that by 3. And that equals the depth of insertion in centimeters at the teeth. So if you had a 5.0 ET tube, a 5.0 times 3, 15 centimeters at the teeth. Now let me open this one and I'm gonna walk back to the camera. This is a 4.5. So it'd be, where would it be? About 13 and a half to 14 centimeters at the teeth. If your paramedic had ever intubated somebody and you did not have breath sounds on one side, then it could be down too far. It could be left or right main stem, typically right main stem intubation, where the trachea comes down and into the bronchus, right and main left bronchus. It could be down in one of those instead of coming up to what's called the carina, where it branches off into the 2 lungs. So it needs to be pulled out just a hair and come back. So now it goes into both lungs. See what I'm saying? It's too far. It's all the way down in just one of them. Real easy to do in a pediatric patient. So these little marks on the side right here. See them little hash marks right yonder? That's the markings. And those numbers would be the tube size at the teeth. That's where you're going. Hold that, pass that back and hold it up in front of the camera so they can see what I'm talking about. Yeah, place that back there and hold that up there, Mr. Yannis, if you will, to the camera. That's us. Hold it up, get her up there. He's holding it up. Y'all see on the virtual guest there, ET tube that he's holding up for you has got hash marks on the side. That is your centimeters at the teeth, depth of insertion. Thank you, sir. And again, ET depth of insertion should be 3 times the size of the tube. Is where the marking at the teeth would be. That's good. Thank you. All right. Moving on. Number 15. What is the answer to it? The normal end-tidal carbon dioxide range capnography measurement in pediatrics. What is normal? That's the emphasis to that question. The emphasis is it is the same as adults. The numbers that your instructors, your educators gave you regarding for adult is the same. So what capnography does is it simply it uses a tool, a device known as a spectrometer, and using infrared technology, it does both. Ms. Whitaker, we hire both. We hire both. All right, so capnography is a pressure measurement. What else do we do in patients? Do we assess that's a pressure measurement? Yeah, blood pressure. It's 120 millimeters of mercury over 80 millimeters of mercury pressure measurement, right? Capnography is also measured in millimeters of mercury. To little m, big H, little g, millimeters of mercury. It is a pressure measurement. Anybody who's a hazmat technician in fire service, y'all may understand about partial pressures. All right, partial pressure. It's a measurement of the partial pressure of the exhaled CO2 molecules coming out your lungs. Nick can tell us a lot about the status of the patient. Moving on. Number 16. Is it acceptable to use CPAP on a pediatric patient? Absolutely. Now, that ain't going to be on your test. If it is, it's probably a pilot question. But we'll use this opportunity to discuss reasons why you would use CPAP on anybody. Give me examples. What are some reasons? So it could be in distress. Could you use it in failure? No. So what type of breathing problem would they be having with their distress where CPAP would be helpful? What about CHF, pulmonary edema? Pulmonary edema in the adult patient is probably due to congestive heart failure, underlying cardiovascular disease and damage from previous MIs, these sorts of things, also known cardiogenic shock, perhaps. In a pediatric patient, the most common cause of pulmonary edema would be inhalation of toxic gases. So a pediatric patient that's been rescued from a structure fire, that's one of my biggest reasons that I like having the capability of doing pediatric CPAP on our ambulances here. Not many other places out there even talk about pediatric CPAP. It's a great tool. It can also be used in near drownings to help push the fluid, the water off of the lungs. It is good for asthma. It is good for COPD. Like I say, we done said it's good for CHF, bronchiolitis, pneumonia. The list goes on and on and on. Any reason that you need to help hold the alveoli open a little longer, because the longer you splint the alveoli open and give a little bit of back pressure against them, instead of letting them just, you let them. That's what you're doing for the alveoli. And it creates a longer duration of exhalation. It gives you more time to let CO2 out, preventing or helping to treat respiratory acidosis. All right. Moving on. What is the defibrillation dose for a pediatric patient? Well, it's 2 joules per kilogram, but here's a better hint. Whatever a child weighs in pounds is what you shock them at first. Now, you would be using an AED, correct? All right. So let me ask you this. For EMTs and the AEMTs, what is it that is built into an AED that automatically determines that for you? The amount of electricity they need. It's called a pediatric dosage attenuator. Now, do you need to know that? No. You need to know, though, that it will give what it thinks they need. And it does this automatically based on thoracic impedance, the amount of tissue between here and the other pad, between the two pads. For a guy my size, for example, you can put that bad boy at 200. Guess what it's going to give me? They're going to give me 200. It's going to give me about 220, 218. I could put it at 200 and I put it on Harbuck. Here, he looked like he needed 2 pieces and a biscuit. Looked like somebody slung a turd out of a red worm sitting there. But anyhow, poor old Harbuck, he's skinny. I set it on him at 200. You know what it's going to give him? Probably 130, 140 maybe. You see what I'm saying? It measures the thoracic impedance anyhow. Even a manual monitor, I may set it as a medic. I may set it right at 150, but it might give them 140. What it actually delivers the shock. So can you use pediatric pads on the adult patient? You can use pediatric pads on an adult patient. Let me rephrase it. Can you use adult pads on a pediatric patient? Yes. But you should not try to use PD pads on the adult. They'll still make contact, but it won't be enough to deliver the amount of electricity that the adult. So you need to be trying to make sure you got the right size pad. All right, moving on, let's go to the next thing. Number 18, we will disregard that. Cardioversion or a synchronized shock, I'm going to teach a different subject with this. And so the reason I would shock somebody or cardiovert them is if they had an unstable tachycardia. So that's a paramedic deal, right? Well, here's what I want to teach for the AEMT and the EMT basic level. I want y'all to know max intensity heart rate. How high can my heart get before the atria quit refilling and I go into a state of cardiogenic shock from an unstable tachycardia? The number 220 minus age in years. For your patient, the highest their heart can get before it's going to have to be slapped into submission, in other words, a cardioversion by a paramedic, would be 220 minus age in years. That is not only in the medical world, that's in the fire science world too. Did you know there's a part of the NFPA guidelines that for firefighter rehab that actually uses this medical science for firefighter rehabilitation? We have that built into our firefighter rehab protocol. You don't, at a certain point, oral rehydration is no longer working. See what I'm saying? And so this is one of the ways you would know that. All right. It's when you got to have IV fluids, that sort of thing. So let me ask, earlier I said the most common cause of a low heart rate in a child is what? Low oxygen. What is the most common cause of a high heart rate in a child or the elderly? Dehydration, low fluid. Slow heart rates in the young and the old are due to hypoxia typically, especially in pediatrics. Low heart rates in kids, they need oxygen. High heart rates in kids, they need fluids. And most of the time, high heart rates in elderly patients need fluids. When would you stop, or when would fluids be contraindicated? When would you not want to give IV fluids? Even if they're in shock. Right. And so when you would want to stop IV fluids or not give IV fluids is if you had congested breath sounds, wet lungs, crackles, rails. You would have to get ALS intercept or get to the hospital where a doctor could do a different way of bringing up blood pressure. There we would be using vasopressors, dopamine, epinephrine drips, stuff like this. If you're giving fluids to a pediatric patient and they develop liver engorgement, right upper lateral quadrant, right up under the rib, almost like a breast trying to develop, or it becomes very rigid right there and protruding. That does not mean you have to stop. That means you need to slow down. You're giving it to them too fast. No worries. And that would only be seen this really, and particularly in a very small pediatric patient who's getting a whole lot of fluid. So they usually get a specified smaller amount, but if you're giving it to them real quick, it might slow it down just a little bit. All right. Chicky. Number 19, my question for you is, what do you use amiodarone for? You don't need to know what the dose is. That's a paramedic's job. But you need to know what they're using it for. That's atropine. We use atropine for a low heart rate. Amiodarone is an antiarrhythmic. It is used in VFib, pulseless, VTAC. So shockable cardiac arrest. If the AED says shock advised, the paramedic's going to need amiodarone and epi. Fair enough? Have you seen these questions on your AEMT test? They're not asking you how to give these drugs or what the dose of these drugs are, but they're wanting you to be a step ahead of the game to know how to help prepare your paramedic partner to give the patient the highest level of care possible. And so amiodarone is an antiarrhythmic. If the AED or the defibrillator is, the patient is getting shocked, they need amiodarone also. So you'd need to be helping the paramedic get out the epi 1 to 10,000, the beige box, and the amiodarone. And the amiodarone is usually in a white or green box, but typically it's in vials, and you have to pull it out with the needle. So, but anyhow, all right. That's all you need to know about that. Now, when would you, or so number 20, what is atropine used for? What is atropine used for? Well, atropine is used for a low heart rate. So bradycardia. All right. You may also see your paramedic partner use atropine if they were getting ready to intubate a child. If they were getting ready to intubate a pediatric patient, they may use atropine to try to prevent reflex bradycardia. All righty, we're going to go. I'm going to go to number 22, and then I'm going to let you, we'll take a quick break, and then we'll kind of pick back up, and I'm going to, we'll trade out just a little. I want you to hear a different voice as we cover some more of this information. All right. Number 20, or excuse me, number 21. Do you know about placenta previa and abruptio placentae? I think by now you have that figured out. Here's what you really want to know. A patient who has had number 22, abruptio placentae, or excuse me, they may not have had that, but that is the reason you don't want to get a refusal in a later trimester pregnant patient who has sustained blunt trauma. Even a low impact MVA with a seatbelt held her, there still could have been shearing forces of the belly in the impact, even a low impact MVA, low speed MVA. Assaults and falls. Why are pregnant patients more predisposed to falling? The balance gets off because now you're top heavy, right? And then now also the hormone changes causes ligaments and tendons to also relax and stretch. And so they're more predisposed to having their ankle turn over, plus they're heavier than they normally were because of carrying a baby. And so pregnant patients are more predisposed than normal to falling. Are they more predisposed to domestic violence? Yes, they are. All righty. All righty. So they may be more prone to be involved in assault. And just being in a vehicle accident, you got the seatbelt. So any blunt force trauma is a likelihood of causing abruptio placentae. So understanding not just what it is and signs and symptoms of it, but also appreciating the greatest risk factors for it, that might be built into some of the questions, all right? Because it would be not best practice to get a refusal on a patient who has sustained any type of blunt force trauma, all right? Now, we will pick back up and we will skip some of this, like this math. These right here, 36 through 45, very informative, very informative. We won't get too caught up on those. And then we have just a few more to kind of hit on that is good information. But when we come back, Ms. Lord is going to present a few, so we hear a change of voice. And then we will, again, if anybody has joined us virtually, please make sure that if you do want some additional information, that you leave us with your email. We're going to go on and we'll take another little quick break. I'm showing 11. We'll say it's 11:05. We will take a quick break here in just a moment, and then we'll go up until noon. And then we'll come back at 1 o'clock specific to AEMT, where we'll review the drugs and how to calculate a few things. And a lot of what's left to know is a lot of good information is covered here. But the big emphasis is sharing these resources with you so you can run down that outline of the registry document. That is where you need to spend the most of your time. So we will take a break, and at 11:10, that's about 6 minutes. At 10 minutes after 11, we're going to pick back up and try to finish this study tool up at that point. We'll be pausing our recording, and our virtual audience, we will join you back at 10 minutes after 11. Yeah, I made an extra one just in case. I didn't stay one, but I got this stable.
I got everything resumed and I unmuted me.
Oh,
So-
are we good to go?
I think so.
We're unmuted and we resume recording?
Yep.
Take it away, Maestro.
All right. So for those of you that don't know me, my name is Kristen Lord. I'm an FTO here at Sumner County. So we're gonna start with number 23. It says, what are some things to consider before administration of adenosine in pediatric patients? So Chubby kind of touched on, we give adenosine for rapid heart rate, and what do we do for pediatrics with rapid heart rates? Fluid. Okay, so even at paramedic level, like we need to be giving these kids fluid before we give them drugs. The next question, it says name 3 treatment priorities with a pediatric patient in unstable bradycardia. We're going to talk about one. So we give fluid to high heart rate. What do we do for pediatrics with low heart rate?
CPR.
Okay, what if it's not that low? Oxygen. Okay. CPR is going to be in your neonate patients for the heart rate under 60. So any patient under 30 days old with a heart rate under 60 gets CPR. It's a good question. Why do you want to avoid the supine position of a female patient who's in the 3rd trimester of pregnancy? Yep. Everybody hear that? So baby lays on the vena cava. We're going to skip over the conversions. They're on your paper if you want to do them. If you have questions about them later, please ask somebody. These next set are pretty important, so we're going to go over them one by one, starting with number 36. So, all right, so we're going to name one field impression that comes to mind when we talk about these patients. So your first patient is an elderly patient who has a fever with respiratory distress and rails. So what are some diagnoses that go with that? Do what? Pneumonia. What else? CHF. What else? What comes with pneumonia in elderly patients with a fever? Do what? Okay, or bronchitis, but what else? What's our big picture problem? Sepsis. Okay. Number 37 says you have a 48-year-old female with neck stiffness, significant hypertension, and a sudden acute headache. What are our diagnoses? Stroke. What else? Do what? High blood pressure, hypertensive crisis. What else? What else can cause a stiff neck? Meningitis. This is most likely a subarachnoid with the headache. Okay, specific type of stroke. For your purposes, a stroke was the first rule out. So the next one we kind of just talked about: headache, neck stiffness, and a fever in a 20-year-old college student. Meningitis. Okay. Number 39. You have an elderly male who's hypertensive, abdominal pain, mid-scapular pain, and leg numbness. Okay, PE, what else? Do what? AAA, that's a good one. What else? What about a heart attack or an MI? Okay. Any patient in the elderly population with any kind of cardiac symptoms, including abdominal pain, is an MI until proven otherwise. Okay. Number 40. You have an overweight 65-year-old male who's orthopenic, hypertensive, peripheral edema, and rails. CHF. Somebody tell me what orthopenia means. Okay. So he said, for those of you that are virtual, he said different blood pressure sitting down and standing up. That's orthostatic. So orthopenia is what? Do what? Okay. It's actually a respiratory distress upon exertion or standing. Okay. It's a change in their respiratory status with exertion. All right. Number 41. You have a postmenopausal female with a history of diabetes. She's nauseated, fatigued, with exertional dyspnea. What are our differentials here? Do what? Okay. Silent MI. Absolutely. Absolutely. PE would be another pretty significant one here. And then your other option, with the exception of the exertional dyspnea, is DKA. Okay. Fatigue, nausea, diabetes.
Oh, that's one of my favorite ones right there. That's a great question. So what do you think that one is? Have they answered it
We
yet?
have. Go ahead though.
Well, what did they tell you?
We came up with a silent MI.
Well, who did somebody answer it, or did you have to
Yep,
coach them?
They came
Who
up
answered
with
it?
it.
Really? All right then, very good. Very good. Excellent, excellent, excellent.
All right.
That is one that people often struggle with understanding the most, so that's wonderful. That's good.
So the next one is number 42. This is acute dyspnea, ventilation to perfusion abnormalities, or a VQ mismatch on waveform capnography in a 26-year-old female who takes oral contraceptives and is a smoker. It's that one, guys.
She's on birth control, she smokes. Now she's got. So,
PE.
Yeah.
Okay.
I want to ask an extra question in the middle. Is a PE a blood clot in the lungs or a blood clot in the blood vessels carrying blood from the lungs back to the heart?
It's in the lungs.
We all think it's in the lungs. That's what most of your instructors and educators will tell you. But an instructor will tell you that. An educator should research it and understand the difference. The reality of actually a PE is it is an embolotic, so it's a clot that travels, that boom, gets caught. It's usually from a big saddle DVT or deep vein thrombosis down in the lower legs from like a cast. And it gets hung in what's called the bronchopulmonary vein. It is the only vein that actually carries oxygenated blood. It's carrying the oxygenated blood from the heart, or excuse me, from the lungs back into the heart. So when that happens, the heart smothers to death from oxygen, lack of oxygen, because the big feeder vessel carrying oxygenated blood, reloading it back into it, is blocked from this occlusion. So the clot is actually not in the lungs. It is in the vessel that carries blood back from the lung to the heart once it's reloaded. See what I'm saying? The bronchopulmonary vein, the only vein in the body carrying oxygenated blood. All right, sorry.
No, you're good. Number 43, progressive onset of dyspnea, drooling, stridor, and a fever in an 11-month-old child. Croup. What do we do for croup? Do what?
Don't agitate it.
Don't agitate it.
Humidify oxygen.
Humidified oxygen. Okay. All right. Number 44 says acute hyperglycemia, hypotension, altered mental status, fruity breath, capnography of 50, and a 28-year-old male who's non-compliant with his healthcare problems. DKA.
And I have to admit on that one, the capnography should actually be a low number.
Yeah.
When I wrote that question, I screwed that up. I was thinking metabolic acidosis. That's what that would be. DKA is metabolic acidosis. Metabolic acidosis would result in respiratory alkalosis. So the EtCO2 would actually be low. Why? Because the patient's breathing fast. The faster they breathe, the more they drop their CO2. So change that, make it say 30. Now it will make sense. See what I'm saying? Understand that respiratory alkalosis is countered by metabolic acidosis. Metabolic acidosis is countered by respiratory alkalosis. Let's take the time and make sure everybody understands that anytime if you see, okay, so they throw in metabolic at me, you need to crisscross that with, so metabolic, that goes to respiratory. Or if they give you something respiratory, the way that would be counteracted by the body would be a metabolic fix. And if it's acidosis, then the other part to the answer would be alkalosis. So the condition that goes with the right answer is always flipped. So if the scenario, if the question reads respiratory, then the answer needs to be metabolic. If the question reads metabolic, the answer needs to be respiratory. If the question reads acidosis, the answer needs to be alkalosis. You understand what I'm saying? Is they counteract each other. The kidneys is metabolic. They buff respiratory, the lungs. If the respiratory or the lungs is the problem, then the kidneys has to buff that. And so that's metabolic. That's kidney. And so so this is a patient who has metabolic acidosis. So he is trying to create what? Respiratory alkalosis. They got to create the total opposite things in both things, the metabolic versus respiratory, and then acidosis versus alkalosis. Put 2 and 2 together and get your match. It's a match game. You see what I'm saying? The reason it's a match game is because it's acid, base, balance. And you got to create a balance between the acid and the base. And that's how the body does that, through either the renal system or the respiratory system. Very good. And so in this situation, the dude is he's creating his own respiratory alkalosis by hyperventilating. That's that Kussmaul's respirations that these DKA patients have. That's why they're doing it. They're trying to fix their own state of metabolic acidosis by creating a state of respiratory alkalosis to balance that acid in the base. It's like a little teeter-totter, what they call it, a seesaw. As a fat child, I was always very careful of who and which I seesaw with. Because you get 4 or 5 skinny kids on the other end, and then them bugs will jump off, and you know what happens. You're going to hit the ground. So anyhow, all y'all in virtual land, y'all can't be laughing at that. Go ahead, Miss Lord,
All
you
right.
carried away, Maestro.
Number 45 says acute dyspnea, chest discomfort, hypotensive, and hyperresonance to the right chest wall of a thin, tall 19-year-old male. Spontaneous pneumothorax. Those are more common than most people realize.
Quentin, will you take a few sips of your water? I need just a little bit more room in your jug. Do that for me because I'm going to borrow your jug here in just a second to teach something, if you don't mind. Yeah, take me a couple good gulps there. Better yet. Oh, never mind. Giannis knows what I'm doing. How much you got in that? Giannis has got me right here. Now, before you answer Miss Laura's question, I'm going to share with you what resonance means. Resonant sound. Mr. Giannis knows what I'm doing, so he's going to let me borrow his Gatorade bottle. So everybody in virtual land,
That probably can't see this, right?
yeah, they probably can't. So I got a container, all righty. If there is no air trapped in the space, when you listen or you auscultate and you percuss at the same time, so you would auscultate with the stethoscope, and then you would listen, you would percuss. So on the patient, I would tap the chest wall. Normal resonant sound. If I borrow your lid. Now, I trap air in the space, such as in a pneumothorax. In the pneumothorax, I will hear a higher sound, hyperresonance, compared to, I trap the air, see the pitch goes up. Hyporesonance would be indicative of fluid trapped in the pleural space. See what I'm saying? All right. So resonant, hyper and hyporesonance is what you have when you auscultate and percuss. And it is used when assessing for pneumothorax, or hyporesonance would be indicative of hemothorax, blood in the pleural space. All right, from chest injuries. So now that being said, go ahead and answer number 42. Or I'm sorry, number 45. Yeah.
We called it a spontaneous pneumothorax.
They did call it. All right,
Okay.
cool. I got you. All right. Yeah, so pneumothorax becomes a tension pneumothorax when you have, so the two key things that I want to share with you, two key things. If you're in virtual land, you need to write this down. Recognizing a tension pneumothorax is more important than treating it. Recognizing it is more important. Why? Because hell, if you don't recognize it, you don't know to treat it. Now, what the paramedic, they can perform a chest decompression, needle chest decompression. Critical care paramedic or doctor, something like that, might even do a chest tube. But you have to recognize the need for it. The two key things that you need to know to recognize that now you have a life-threatening breathing emergency. B, breathing, primary assessment. If you have absent breath sounds on the affected side and any blunt or penetrating chest trauma, and that it causes 1, absent breath sounds, 2, hypotension. When those two things are there together, honey, you behind the 8 ball already, you need to get her done. If that progresses, it will not only it will not only do you have a tension pneumothorax, but that will lead to a cardiac tamponade. And now you have a breathing emergency and a circulation emergency. And that was what we'll put, that is obstructive shock. The patient's blood flow is obstructed because there is a cardiac tamponade. It is twisted off the inferior and superior vena cava. Blood carrying oxygen back into the heart can no longer occur because of the obstruction, pericardial tamponade or cardiac tamponade. All right, that is caused by trauma patients. That can be caused by an untreated tension pneumothorax. Why do most tension pneumothorax go untreated? Because they're not recognized. Therefore, it's important for everybody to know how to recognize them. Wouldn't you agree?
I do agree.
I'm glad you agree. It makes me feel better. All right, what's next?
All right, so the next section is the airway breathing section. We're gonna look at some of these capnographies. All right, so number 46 says, what condition do you expect the above waveform? So Chubby asked me earlier what I would expect to see in asthma patients, and I told you a shark fin. This is what we're talking about, okay? It's not flat like a normal plateau.
What medicine would that patient need? Albuterol. They're experiencing a bronchospasm, so they need a bronchodilator. They need a beta agonist medication, albuterol. Any kind of medicine that is known as an agonist means that it helps something. Something that is an antagonist means that it works against. So give me an example of an opiate antagonist. Narcan. Narcan works against opioids. So it is an opioid or opiate antagonist. Albuterol works to help the beta effects of bronchodilation in people who are having breathing problems. So it is a beta agonist. See what I'm saying? Agonists versus antagonists. If I'm antagonizing you, am I helping you or hurting you? I'm hurting you if I'm antagonizing you. If I'm egging you on, am I supporting you or telling you to quit? I'm supporting you. I'm making you go better. All right. So I'm egging you on. So anyhow.
So to talk about capnography a little bit, this down spike is your inhalation, and this is your actual exhalation. So it's backwards from what you would probably think. So these patients are having a hard time expelling air, which is because of the bronchospasms. Okay. It kind of helps you understand why the shark fin. So this patient, it says one possible cause for an abnormal waveform capnography. So we talked about this as the inspiration, okay? And then this is the expiration. But what happens when they try and do it again in the middle? Right. It's typically your patients that are RSI or intubated that aren't sedated properly. Okay. So if you see this, you need to be alerting your medic of, hey, I see a clef or I see something that's not right, because there probably needs to be some additional sedation for this patient. They're just trying to breathe in the middle. All right. So number 48, what is the likely cause of the sudden increase in CO2? ROSC. ROSC is the number one cause of an increase in CO2 like this. Okay, so you have the patient intubated or with a king airway in, and you're ventilating, and this is your capnography, and this is your capnography, and then all of a sudden you get this significant spike. It's time to pulse check that patient. Okay. So that's the most likely cause. Now, so here's the next one. What is the most likely cause of this sudden decrease? Cardiac arrest or? So we have a tube. Yeah. So we have a tube here, right?
Right. Tube came out.
Tube got displaced.
Or your ventilator's not working right.
Or the machine's not working. So you go back to that dope mnemonic you kind of talked about earlier, but your primary concern here is that your tube became displaced, or the patient stopped breathing if they aren't intubated or on a vent.
Or if it, yeah, that's right.
Okay. So he said you talked about this.
So does everybody feel comfortable in your emergency cardiovascular care compression to ventilation ratios? Who gets 3-to-1? Neonates. All righty. So very good. Now this is not asking compression to ventilation ratio. This is asking, okay, so they still have a pulse, but they are not breathing. So this is artificial ventilation, which is also known as rescue breathing. This is the whole one breath every how many seconds?
So what is it for an infant? What's the rescue breathing rate for an infant? Do what? Yep.
Yeah. About 1 every 2 to 3, and then child. Is that better? Yeah.
3 to
older
5,
child,
yeah. And then the adult with the oral airway,
Back it up. 1 every 5. 1 every 5 seconds. Some texts may say 1 every 5 to 6, but go with 1 every 5.
and then with the ET tube in place.
Now that's
About
slower.
every
Yeah,
6.
1 every
Yeah.
6. The AHA says 1 every 6 to 8, but earlier I showed you where the registry document actually said 1 every 6 seconds. Now, the thing to park on this for just a minute, I'll steal your
You're
thunder,
good.
but I want you to understand if there's 60 seconds in 1 minute of time, 60 seconds in 1 minute, 1 breath every 5 seconds is a rate of how many a minute? 5 into 60 goes 12 times. Excuse me. Clear that up. Let me catch it.
Good. And then, so if it's with the ET tube in place every 6 seconds, it's how many a minute? 10. Okay. All right. So this next question, 54, we're going to talk about nasal airways. So when is it appropriate to put in an MPA? Okay. The contraindication is facial trauma. It's not a true contraindication, but it's definitely not something we want to do if we don't have to. Okay. But it's acceptable to put it in patients that are in respiratory failure. Okay. That we need an airway on. Patients that still have a gag reflex. Okay. 'Cause you can't put an OPA in if they have a gag reflex. All right. We're going to skip that question. This is the RSI stuff. Okay. So 57. How do we verify placement of a king? Lung sounds, gastric sounds, capnography, pulse ox. Okay. What do we have to do to a king once we place it and inflate the bowl? Secure it, but we have to pull it back to seat it, right?
Yeah.
Make sure that you're seating those kings before you secure them, but always secure them, same as with an ET tube, okay? So the placement for an ET tube is pretty much the same, right? I want lung sounds, no epigastric sounds. I want a colorimetric device. I want capnography. All of those things are to help back you up that you're really in where you're supposed to be in, okay? So describe the findings that would justify a needle decompression. So we just kind of talked about pneumothoraxes. So if they have hyperresonance, if they are hypotensive, if they have absent lung sounds on one side, okay? It's kind of what we're looking for to do the needle decompression. And most of that stuff is stuff you guys can identify for us, right? All right. What is the difference between CPAP and PEEP? So what is CPAP? Okay, and what is PEEP? Peak and expiratory pressure. Okay, so CPAP gives you pressure continuously. Your PEEP is the actual number of pressure that you exhale. Okay, does that make sense? What is the number one contraindication to a CPAP? Do what? They're not awake. Respiratory failure. Altered mental status. Those are your true contraindications to CPAP. We're going to skip over the meds because he said we're going to talk about those after lunch. So we're going to go to question number 71. These are terminology questions. So what word means above? Yep. Superior. What word means away from? Do what? Distal. Okay. What about if I'm taking my arm and taking it away from my body? What is that called? Abducting, because when I put it back, it's adducting. Okay.
Take away, if somebody takes away, they kidnap somebody, they're abducting them. Take it away.
And I always remember that I add it back. So it's adducting. That's how I separated the two. So, all right. What bone is distal to the patella? What bones are distal to the patella? Okay. And then it says medial of the fibula. So that becomes the tibia, right? How many bones does the human body have?
I thought it was 216.
206.
206.
An infant has 216.
Yeah, before they're fused together. It's very good. Did everybody hear what Mr. Yanni said there? And yeah, so about 216 when you're brought into the world, and then with what fuses together in the skull, etc., it ends up at 206. Very tall people, well, somebody such as myself, I actually have an extra lumbar vertebrae, which after 22 years in EMS, I start feeling that joke with somebody. I'm pretty sure that was the one that shot through my hind end the day we hit a bump in the old Wilson County Medic 21. And what, you should never launch an ambulance. You know, that was that thing you see on YouTube, the crazy guy, just send it. Yeah, don't do that with an international ambulance. Back in the late 90s, early 2000s. Air ride suspension does not work well. No. I felt it that day and I still feel it.
Still feel it?
But I was a dumb young rookie, thought I was invincible. And all these years I've continued to ignore it. But anyhow, now that I'm fat, 40, and working an office job, yeah, I feel those things. So I bet I'm gonna get on truck this Lord to care myself.
Is that what we're gonna do?
Yeah.
How many oxygen molecules can each hemoglobin protein carry? How many?
4. Excellent.
4.
Where did you learn that? Who's your instructor?
Johnson.
Eric
Johnson.
Who?
Gregory Johnson.
Oh, excellent. What an amazing individual. Wow, wow, wow. What an amazing story he has as well. Powerful. I'm gonna text him and tell him one of his students just answered a complex A&P question. Oh, keep going.
Okay. 76. Where would you see perioral cyanosis? Okay, so oral's in the mouth, the lips. How many thoracic vertebrae does the human body normally have? Okay, so how many cervical are there? What time is breakfast? 7. Huh? 7. What time is lunch? That's how many thoracic there are, okay? What time is dinner? That's how many lumbar there are, okay? Everybody got that?
Yep.
Breakfast is at 7. That's your cervical. Lunch is at noon. That's your thoracic. And lumbar's at dinner, and that's 5, okay? It's just how I was taught. It's an easy way to remember it. So what is the normal pH of the body? 7.35 to 7.45. Blood travels back from the lungs, back to the heart via which vessel? Yep. What are your solid organs? Kidneys? Pancreas? What else? Spleen. Cardiology. I skipped over the meds so we can talk about them after lunch.
That's kind of the AEMT. So, there is some trauma. Oh, yes. And as a matter of fact, let me just say right back there. In that outline that we were looking at, there is information to know on trauma. A couple of quick things before Ms. Lord breathes us through there is an exsanguinating extremity hemorrhaging. In other words, mass arterial bleeding from the extremity. Tourniquet placement, right? High and tight, y'all know how to use tourniquets. You don't need me to talk to you about tourniquets. But for junctional wounds, obviously direct pressure, then hemostatic agents such as comeback gauze, quick clot gauze. We do not pick the answer that says quick clot powder or don't pour hemostatic agent or powder onto these wounds. All right, that is no longer accepted best practice. You want to pack the wound with the hemostatic impregnated gauze and use that. All right, and otherwise, moving on here, number 86 answers some more of this.
Okay, so number 86 says approximately how much blood loss occurs before the patient becomes hypotensive.
3 liters.
2 liters.
It's 2 liters.
So what you're looking at on that is on this one, it is 20 to 25% of their volume. In a pediatric patient, they only you lose about 20% of their blood volume, and they will go from compensated to decompensated shock. In other words, become hypotensive. Remember, hypotension is the defining factor between compensated and decompensated shock. In trauma, they got to lose about 20% of their blood volume in children to become hypotensive. When they become hypotensive, boom, that's decompensated shock. In adults, it's about 25, healthy adult, about 30%. So if it's 20 to 25% based on little to older children and 25 to 30% based on most adults to healthy younger adults, a good average number, if you can't remember anything else, is about 25%. Just understand that those are the specificities within the depth of the reading. The reason that so you need to understand that the average adult male's got about 6 liters of blood in his body. Average adult female's got about 5 liters of blood in her body. Pediatric patients have got about 50 to 70, depending on years. So little bitty kids got about 50 milliliters per kilogram of blood in their body. School-age children is going to be more along the lines of about 70 milliliters per kilogram of blood in their body. Your average arterial wound can leak 5 to 10 milliliters of blood every time your heart beats. So what does that tell you? That tells you that the time you're going to go hypotensive and probably be out of fight in blood loss, you're looking at a minute and a half, maybe 2 minutes of true arterial bleeding before you're going to go boom into crash hypotension. You're going to be out of fight, not in just a few more minutes, exsanguinated to the point of irreversible shock death. So the loss of generalized blood pressure will cause a loss of cerebral perfusion pressure. So you're going to go unconscious before you even die when you do blood loss. So this is why we got this big emphasis on stop the bleeding. Stop the bleeding.
What's hypotensive in a pediatric patient?
Oh, yes.
70 plus 2 times
The
years
age.
or age, yeah.
70 plus 2 times the age in years.
Anything less than that is critical. That's hypotension. 70 plus 2 times the age in year.
What's normal tensive for a pediatric patient?
Oh, that's good.
Normal tensive for a pediatric patient.
Normal.
90 plus 2 times the age in years, okay?
I was looking at the notes.
And we don't focus very much on diastolic pressures for pediatrics because in reality, it's very difficult to even obtain a systolic. I've been standing at Vanderbilt Children's ER before and hear the radio report called in with other ambulances, and you can hear sirens and air horns, and you can hear the bumps on the road, literally, where they're coming down West End. And they, such and such county medic 12, Vanderbilt Children's, go ahead, blah, 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 this, blah, 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 have a, 2.5-year-old, blah, 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 such and such on the Broslow color, weighs approximately, have a blood pressure of 111/64, and I'm like, boo. They're gonna wait, you heard that blood pressure, I'll tell you what's happening, I wrote air horns, sirens, and $20 decibel. Therefore, don't get caught up in diastolic blood pressures in children that young. That's the point there. We focus on pediatrics, emergency medical, we focus on systolic.
So Brent kind of covered this. When it's acceptable to apply an arterial tourniquet, anytime you have an arterial bleed.
Would that become before or after airway and breathing issues in the same patient? That's right. That's right. Like an unresponsive patient, the patient who requires tourniquet placement trumps airway and breathing. Circulation trumps airway and breathing on that. It goes before. So very good.
How would you splint a critically unstable patient with fractures to the arms, leg, and hip?
To a blackboard?
To a backboard.
Yeah, it's a splint on it.
Backboard's a splint.
Yeah. Correct anatomical placement and roll with it. I have brought more than one patient, you probably have too, Miss Lord, over the years, into level 1 trauma centers. And they both bones and legs broke. And do you think I had anything splinted in there? I didn't have time. They ain't got time to split it.
Yeah.
And they'd be like, we got a bone sticking out down here. It's like, very impressive. I must have missed that. I'm sorry, but two sets of eyes, 2 hands. I have been at Vanderbilt ER before, and we get toned out around the corner, Mid-Center and 21st, or Medical Center Drive and 21st Avenue, man hit by a bus. Well, hell, I was on him and loaded and coming back around the corner to the level 1 ED, just trying to manage his airway and bag him. And so is it acceptable to roll into a hospital and never even have an idea what their blood pressure is? Yes, because blood pressure is secondary assessment. Sometimes you'll never get past primary assessment. So it is perfectly okay to not have an idea what the blood pressure is. Make sense? You see what I'm saying? Yeah, you stuck on a primary problem. You ain't had time to look at secondary.
So there's 2 more questions. Number 89 says, how would you manage a patient who has facial trauma from an MVA that presents with snoring respirations unrelieved by the repositioning of the head? Do what? An OPA if they'll tolerate it. If they have a gag, then we're going to put in a MPA if we can get one in. Okay. The ultimate goal for this patient is RSI and intubation. So just know for your paramedics purposes, you're going to want to be thinking about setting up intubation stuff. Okay. The final question says, describe your interpretation of permissive hypotension. So what is permissible or permissive hypotension?
And this is more of an AEMT thing, but EMTBs, everybody needs to know this. AEMTs expect a question in your trauma section about this.
So when is it okay to have low blood pressure?
Do what?
It's asking when it's okay to have low blood pressure.
Correct.
She's rationalizing and she's using common sense. This is a useful tool when taking the National Registry tool. Test. This is also a very useful ability when running EMS calls out here. And so, Ms. Lord, tell us about permissible hypotension.
So so it's basically, when is it okay for the patient to be hypotensive?
90 systolic.
Right. So when is that okay?
That ain't a bad time, to be honest with you, but this is specific to trauma. So trauma and hypotension, when you see hypotension as an AEMT, what do you want to do for the patient? They got low blood pressure, you want to give them fluids, don't you? Well, what is the trauma triad of death? Does anybody know what 3 things IV fluids cause in the trauma patient?
You can push blood out.
So if I thin the blood, is it going to clot as easily? If I thin it, if I wash it out with fluids?
No.
So it causes coagulopathies. If the human body needs to be at 98.6 degrees to maintain homeostasis, and I reach inside the compartment and get out a bag that's at room temperature 70 degrees, hypothermia, cold blood don't clot. Hypothermia that is as subtle as 96 degrees can begin causing the patient to lose the ability to clot. The body's way of trying to stop the bleeding on its own. And then the third thing, earlier we talked about the pH of normal saline, did we not? 5.5 to 6.0. What's the normal pH of somebody? 7.35 to 7.45. So I'm causing a left shift of my pH scale. When pH drops, it becomes acidosis. When CO2 rises, it's acidosis. When pH drops, it's acidosis. See what I'm saying? Now, I just confused the hell out of somebody right there. But after lunch, the AEMTs, if you will remind me, acid-base balance, and to talk about what I just said, I'll put that out here. And we'll help drive that point home so you'll nail those questions when you get them. Yeah.
So that's the end of the questions.
So,
It's noon.
yes, and so the other thing just to know about that is you're looking to maintain 90 systolic. If it's lower than that, then and only then would you consider giving fluids to the trauma patient.
Trauma patients.
So you're
Describe
looking
your
to.
interpretation. So in a
Only
trauma
give
patient, you
fluids.
want their systolic to be around or above 90.
Yeah.
So hypotensive isn't hypotensive in a trauma patient until it's under 90
And
systolic.
what the registry document itself actually says, it no longer goes off of 90 systolic. It says a goal mean arterial pressure, a map
65.
of 60 to 65. Yeah, excellent, excellent. All right, let's show some resources here. Thank you. For those who are with us on virtual land, I have seen a lot of emails come through. We will record those. And what we're looking at doing is I'm going to share a new part with you here. So we will we're going to look over this after lunch as well, but I want to send this information out because it goes on down into some of the specifics of the information. One of the things that it even said, we will teach later, but everybody should understand things of this nature. Even though the BVM can give it, don't mean the patient needs it. These are big, big things that you must understand in your respiratory airway management questions and these sorts of things. You need to know sounds like paramedic knowledge, but it's not. These are possible preventions or corrections for cardiac arrest in the patient, things that you can do to fix them once they go into arrest or to keep them from going into arrest. We can talk about that, but the list goes on and on and on. There's even material that you need to know now in the ECC, or emergency cardiovascular care, that even talks about LUD, left gravid uterus displacement, how to do chest compressions in a pregnant patient. This is the same reason that you would put them on their side if you have to immobilize the pregnant patient, to get the compression of the baby in utero off of the inferior vena cava. to prevent, so when you're doing chest compressions on the pregnant patient, this is how you have to do this. And then we have a lot more information, but in a short amount of time, it is difficult to cover everything. So we will send this out. We will also be sending, like I say, the link that we were looking at earlier with the National Registry material. Some of the stuff here goes on down all the way to the operations section. And that's something that we want to take a close look at. This being said, anywhere where it says skills, under at-risk population, you think that that means geriatrics, and sure, they're at risk, but here's the people this is focusing on. It is asking us as EMS professionals who are going to be in the field out here to make sure we're not overlooking something that's right under our noses. So you would need to click on these links right here, and it takes you to some Department of Homeland Security awareness information to teach, and you could expect to see questions about that in the operations section. Human trafficking and domestic violence. And a sad pill to swallow is that in domestic violence, it's not just some guy that is on the scene who may be beating up on a spouse, but it's also the prevention and the how to address domestic and violence that can occur in providers. Because of the stress we carry and whatnot, we don't need to carry the drama home. And if you've done this long enough, there's probably somebody around you who shares a uniform who may be the aggressor or the person who's been subject to domestic violence. That's something we can't allow. So these are examples. Then there's the pediatric and the geriatric, these sorts of things in those patients. So this is included in operations. Then you have ambulance safety. This is where we're going to be, you're getting some of your driving questions, some of the usage of safety equipment such as cot strap, shoulder straps on the cot. And 15% of each section is pediatric. So guess what this one's probably going to ask you? How to best immobilize or how to best transport a pediatric patient. In the patient, in the mother's lap or the daddy's lap, the caregiver's lap is worst practice. So best practice would be in a specifically designed child safety seat if the child is stable enough for this. Even in unstable children, there are safety devices made now to do this. This talks about ambulance crashes, which is a very real, very big thing that we have to be aware of. All righty, and all the pushes. So this is the things that have been done to try to, so now we get into field triage. So field triage, something I want, before we leave, that I want to share with you real quick on field triage. And we come back after lunch, we could look more at this. But the one thing you need to know before you leave, especially those in virtual land who are staying for the basic part, I want everybody to know you're more than welcome to join us back after lunch, which will specifically look into advanced EMT information and some of the drugs and this and that, IV fluid and use. But if you do not plan on joining back, then at least hear this. So before you black tag any patient who appears to be dead in a mass casualty incident, you have to first and foremost provide an airway. And because it is a trauma patient, most likely you would do this via the modified jaw thrust. If the adult patient does not show any signs of respiration, once you give the airway, they still don't breathe, then and only then could you black tag them. You would try to sheet them, cover them, whatever you can do, move to the next. You may not have the time nor equipment in order to cover them, but you got to move to the next. The easiest way that you will locate your red tag and your black tag patients in an MCI is you find butts in the air. From the earlier stages of infancy, a human being develops the ability to roll over, to put their face up. But if somebody is so critically injured that they have at least not got into a position would put their face up, so they're prone, face down, butt in the air, then they either critically injured, red tag, or they're deceased, black tag. So you would log roll them carefully, try and provide an airway. Then and only this, so if they are not breathing and have no pulse in an adult, that can be declared deceased in an MCI. A one patient, one car rollover MVA with one ejected, I'm obviously going to work that patient, right? I'm going to try to do what I can for them, but in an MCI, I can't do that. Now, a pediatric patient who is unconscious and does not appear to be breathing or have pulse, give them an airway. Then if they are not breathing, what you have to do on a PEDS patient is give 5 rescue breaths. This is jumpstart triage. Jumpstart triage. You see the difference in the objectives here. Again, like Chief said, where it says lesson objectives, that's where the bulk of the questions that they will ask you will be. Those are where you can expect questions. So jumpstart is PEDS. So in PEDS, so you give them an airway, you give them 5 rescue breaths. If that stimulates them to breathe any on their own and shows any signs of life, then they become a red tag and they're one of the first buses out of town. They got to be on one of the first ambulances for transport. They get treatment and transport as a priority patient. If they remain apneic, no signs of life, without pulse, after those 5 rescue breaths in a PED, then you can also, just like the adult who doesn't respond after opening their airway, you would black tag that patient. That patient would become deceased. That would be declared deceased. Now, walking wounded, those are your green tag patients. The best thing to do, if you can hear my voice, I need you to come here where we can give you some help. Draw the flies to the light. That sounds bad. This is also the reason we set media up at an offsite location to try to draw them away. I don't need the extra confusion and stress of having to deal with media on top of that. Some's going to show up anyhow. But the sooner we can get somebody to set up a PIO checkpoint to come, the media, hey, I have information, come get it. That drives them away from that immediate scene because I don't need them being there for all that. Sometimes you can prevent it, sometimes you can't. We also have some obligation, right, to try to inform the public. But that's like ICS. We won't even get into that. All right, but in triage, so I need a green, walking wounded. You want to try to funnel them towards a choke point. What is a choke point? An example, the main entrance of an office building, the entrance into a subdivision when a tornado has hit. Those are good examples of choke points where you can try to bring everybody towards the end, the bottom of the funnel. And there you can really make sure that you're not missing somebody. And then once you get all the ambulatory people out the way, now we can come in and see, we have other teams moving in looking for those who aren't moving. So you got one laid up against a wall. Now the question, so they're not walking wounded. They're still alive, obviously. So they're not a black tag. They're not a green tag. Well, they're going to be red or yellow. So the 3 things that now differentiate yellow versus red, they may be sitting there with an open fracture of the leg and an arm that's bleeding badly. You want to try to treat them if possible, you know what I'm saying? So they don't become red if they're not already, but you get the point here is what I'm saying. The thing that makes the patient red over yellow, so yeah, they're not ambulatory, so they're yellow. But when they're red would be any one of these 3 things. Altered mental status. In an adult, the respirations would be greater than 30 or less than 8. In a pediatric patient, respirations greater than 45 or less than 15. In any patient, absence of a distal pulse. Any one of those 3 things is justification to say the patient is red category. They need to be high priority for transport over all other patients. Make sense? The other exception to that is any rescuer on scene in an MCI who becomes a casualty themselves. An example, you stepped in a hole over the debris and broke an ankle. You just have an ankle fracture, but you will treat that as a red tag. Number one, you got to take care of your own. But number two is the psychological effect. When the emergency lights and sirens show up, we just restored hope. They're here to help me. But when they see you go down too, now that's going to breed more confusion and chaos and stress that you got to have to manage. So you've got to get them, you got to get an injured rescuer out of sight. You see what I'm saying? That becomes a red. You got to get them out of there. All right, because that's going to make things worse on the whole psychological reaction from the other casualties. All right, so now, then all that being said, so those three things identify the red tag patient: altered mental status, ineffective respirations, and absent distal pulses. Those are signs of immediate unstable physiologic findings. So you got to deal with that. All right. And on with the ops. I would strongly recommend looking over all this. Talks about hand hygiene and cleanliness. You need to be aware, and also vaccines. You're not going to see discussion of COVID vaccine because that's not something that's necessarily FDA approved. But what we're still talking about is all the old school stuff that's been around for a long time. And there is information that may ask you about this. And this right here would be, guess what? If it's something you think it may ask you about, do you think it will, right here though, objectives, this is where you will find, yes, it's liable to hit you up a question on it. So anywhere there's a blue link is where you will find the answer to what the potential question may be. Next is culture of safety. This is talking about crew resource management. Well, crew resource management is a just culture, but a culture of safety. This is along the lines of like driver safety, but also lifting safety, research and development of better protocols and procedures to try to reduce injuries. All righty. And this would be along the line also. And then the concept of a just culture is in ties with crew resource management, which is a new, shouldn't be a new, but it still in some places is, concept in emergency services, adapted from the airline industry. In other words, it does this right. In a just culture, people are no longer afraid to report near misses out of the fear of punitive actions. In other words, we're willing to accept some failures and learn from them to make better processes, to prevent them later. And so that's what it's trying to emphasize. It's one of the things we actually try to do here at our service as well. You know, if somebody goes out here and makes a mistake on a call, it's not all about writing somebody up and suspending them or firing them. Whereas more or less, I take a lot of ownership of these things. If they do something wrong on scene, it's my fault, right? If I'm the training guy, should I not have trained them to do it the right way? So when they knew how to do it the right way and still chose not to, that's a different story. But this is what it's talking about. It's the way we kind of need to develop and guide our industry. And then you see pediatric transport. Guess what? That's your 15% of some of your PEDS questions. They can come from MCI triage or pediatric transport. All right. And then, boom, that's what it was talking about, the crew resource management. I wouldn't get too deep in this one. I would breeze over the category. Specifically right here, the benefits of CRM, looking to minimize errors. All righty. This is like some leadership type stuff that everybody's expected to know now. You may get questions about this. All righty. And, but this is information that you don't you don't think, when you think operations, you're thinking of driving, getting consent, putting on gloves, you see how to work a radio, that kind of stuff. That was yesterday's operations. When I went to EMT school and took my test, that was yesterday's operations. Today's operations content is still some of that, right? But it's on a level that we never thought we would reach because of the development of the industry. All right. So this is why a lot of instructors continue to teach the old school operations knowledge, and they fail to dive deep into some of the evidence-based guidelines and other things that have developed and matured the industry into the direction we're trying to go. So therefore, we need to make sure that we take a chance to look over this stuff. All right, enough about it. And so that's what we will be sending a link to everybody out about that. And then the other link would be to a direct link to save your time and effort. Takes you right to the American Heart Association's guidelines for emergency cardiovascular care. I highly recommend that anybody who is looking to pass the test would look at those things and take a close look. And the other thing that we'll end with right now, and we will pick back up in an hour. All right, it will take an hour for lunch. You come back for your AEMT knowledge, and then those virtually can join us back. You can join back in to the same link. We'll fire it right back up after lunch. But here's what I want to tell you before everybody leaves is it took me, I think it was 3 or 4 times. I think it was the 3rd time I passed EMT basic. When I did it, we didn't have advanced. We had IV in the state of Tennessee, so that was a state upgrade. So then I had to take registry again when I became a paramedic. And it took me 4 times to pass my paramedic test. And that makes you feel like a total idiot. Or like maybe the place where I came from, there is some pictures in my office in here. There's 2 photos. There's a group of some guys at a no rescue squad with a green 18-year-old rookie on the end. And the other picture is a picture of a wolf. And it says, "Throw me to the wolves and I will return leading the pack." Where I am from and where I had planned on getting my first EMS job and spending my entire career, while I was doing a clinical, I had been washing ambulances, cleaning the station, trying to everything I could, trying to make them like me. And I walked out in the bay and I heard them out there making fun of me behind my back and talking about me. And I said, "He ain't much." And they was right. I was just a dumb rookie, man. I didn't know any better. I was gullible, green, sheltered, 18-year-old kid from all good Tennessee. That's why now when I jokingly tell people, "Hey, you ain't much," it's because maybe they wouldn't, but now they have my respect. You see what I'm saying? Now they awesome. So I won't ever tell you ain't much unless you're awesome at it. You know what I'm saying? The ones in our service here, they know it's one of Chubby's sayings. It's like you pull a string, you ain't much. But yeah, but here's my point. Is that makes, and then when I finally got my first interview, they gave me an interview just to shut me up and to get me out of the way. The man had the balls to tell me, "You're a real good old country boy. And maybe you might be a good dispatcher, but this just ain't for you. I've heard from a lot of our folks, we just don't see it in you." And when I heard that, I was getting my test passed and all this, and I was going to pass my test, but that killed my spirit. And I was already not as smart as I should have been, perhaps. I didn't know any different. My poor mama had done everything. My best friend's mother paid for school because my own mama couldn't afford it. She's doing everything she could to keep me and my brother going. Working as a nurse in geriatric care. And I've been beaten up and defeated my whole life by the one who should have been my biggest encourager, my daddy. That wasn't there. So what you have to understand is everybody here got a similar story, something that's tried to keep you down. That was one of the hardest things and the most difficult, but the most beneficial things that day that the man that I got to interview with ever told me. And he was like, in my mind, the great Oz, you know what I'm saying? Now he's still a large figure in the industry up that way. Now he's actually county mayor of that county. However, multiple times over the years, I have traveled back to my hometown to teach leadership classes and to teach them how to implement FTO programs and to speak to students like this in that region. And I have stood in the conferences and spoke to a room full of hundreds of EMS leaders, and then at a different conference, rooms full of EMS educators. And in those rooms sat the people who told me 22 years ago that it just was not for me. They are now some of my closest and most respected friends. Now I am the one on their radar instead of me having them on my radar. Throw me to the wolves and I'll return leading the pack. And in my lifetime in this business, it's one of my greatest accomplishments is that very saying and that very photograph in there. I have took ownership of that. My friends out here on the virtual audience, I want you to hear what I'm telling you. I remember when I was driving to Memphis to take my refresher test so I could test for the 4th time in a truck that I did not think was going to make it. I left out at about 2 o'clock in the morning to give myself plenty of time in case it broke down. I was going to walk if I had to. Hell, I didn't know. I was so desperate for it. I was so defeated. I had on the way back, I had to stop on the side of the road and scrape up pocket change in the floorboard and stuff just to try to put gas in it. Because I knew if I could get back to the fire hall that Friday afternoon or that before close of business, I could pick up my check. And if I could pick up my check, I could put gas back in my truck and go on about and you see what I'm saying? I mean, I was damn broke as hell. I was broke as hell. My heart, my spirit was broke because I thought what I loved to do, what I was made to do, and my purpose that I was trying to pursue was just not going to be fulfilled. And I was struggling financially, I was struggling emotionally, all these things, like lots of you may be sitting here doing. And I was doing everything I could, beg, borrow, steal, sell what I had to sell because I was having to pay for registry test after registry test after registry test. And I didn't have nothing. Well, in the keys to my pocket goes to about an $80,000 truck that I got the title to. My home is just under, appraises for just under $1 million. We got a lot of equity in it, thank the good Lord. I don't have that kind of money in it. I make very good money in the world of EMS, sitting here now doing what we do. But what I've told you, my friends, is to motivate you and is to inspire you and is to tell you that sitting here listening to me right now is the next person that could be standing up here leading people to fulfill their purpose, all right? Do not let this own you. You own it. Do y'all hear what I'm telling you right now? This test is nothing. The real struggles come at 2 o'clock in the morning when your beloved colleagues, the people you would kill or die for, call you on the other end of the phone and say, man, I don't know if I can keep living because of what I've seen and what I dealt with. And they say, man, I'm trying to pick up all the overtime I can. My kid's medicine is costing us $1,200 a month. And I'll do whatever I can to keep him alive. You know, y'all get any overtime. And can you help me get renewed? You know, I ain't gonna be able to make this class because I got to work this shift. I got to have this money. And I bend over backwards to get them the class and the training they need. You see what I'm saying? That is why these classes, I've never charged a dime for them. Multiple of these companies out there that do online training and stuff have reached out over the year, just in the last couple of years, trying to hire me. And it ain't about that. It's about making sure that we help prepare each other for the real challenges ahead. This test is not the challenge. The challenge happens when you find out that the pediatric patient is under the car still And once you get him out, it's go time. And now it's really your time to shine, not on the test. So this right here is minimal. This is minimal. And every one of these scenarios I've lived multiple times that I'm talking about. And do you think when we save that life of that person, or we learned to sit and cry together because we had to accept a loss, did any of us sit and think about how many times I had to take the registry test in order to do it? Hell no. So, but for right now, I'm gonna get you through this, and then we'll worry about the real challenges. Fair enough? All right, everybody in virtual land, I appreciate you joining. I am looking at my time. We talked a little bit. 1:30, at 1:30, we will go until 4 p.m. At 1:30, we will rejoin. You can use the same Zoom link, and we'll go from there. Love you, mean it.
So do you go?
Where'd they at?
Same place as always?
I'll probably get with what I got.
You know what?
Yeah, I got a bunch to do before we get started. Appreciate it though.